this webinar, which is based on awake regional anesthesia, which is the theme of this particular lectures. And this is organized on behalf of ESRA and Arora and the BRAC. So Arora is the national organization of India regional anesthesia, where we are 2,500 delegates strong, and we'll be having our conference in September in Amritsar. And I also welcome you all for this conference. And PRAC is Pune Regional Anesthesia Conference, which also is a part of Aura, and we hold this conference in Pune every year. So this year we are going to organize on the May 31st and June 1st. So we have a couple of lectures, very interesting ones, and top-notch speakers throughout this webinar. And the webinar will last for 2 hours, and with 15 minutes talk in each of these sessions. So Dr. Anju Gupta, who is a colleague of mine, and she is based in New Delhi, AIMS. And together we have organized this particular webinar. So I hand it over to Anju Gupta. Thank you very much, and see you soon.
Thank you, Sandeep sir, for your kind words. I thank all the speakers for taking out their precious time to celebrate the World Regional Anesthesia Day, which is a celebration of unity. As somebody said, alone we can go fast, together we can go far. So I think this is the apt message for today. So with that message, I'll begin with my talk. There is some problem with screen sharing. Please excuse me for the technical. Are my slides visible?
Yeah,
yes, ma'am.
Yes, we can visible. You can make it a slideshow.
Yeah. Very good evening to all listeners from across the globe, and a very happy World Regional Anesthesia Day of Regional Anesthesia and Pain Medicine today. So we all have gathered today to celebrate this second World Day of Regional Anesthesia and Pain Medicine. And in this regard, we will be having some talks on regional anesthesia for awake regional surgeries. So I begin with my talk on spinal anesthesia in preterm neonate for gastroschisis. A warm namaste to all listeners. A little bit of introduction about my institute. This is the Apex Premier Institute of India, which is catering to a patient load of around 15,000 per day with 60 departments and 9 specialty centers. So I have nothing significant to disclose here. And first of all, let me begin with some milestones in relation to pediatric spinal anesthesia. Spinal anesthesia was introduced by August Bayer in 1898. By 1933, it was even being proposed for pediatric thoracic surgical procedures and even cardiac procedures. However, subsequently, it went into disuse, probably due to advent of better general anesthesia drugs and increased safety of general anesthesia. Then Abhijan et al. In 1984, in this landmark description of 28 cases, he reintroduced spinal anesthesia as an alternative to general anesthesia in high-risk preterm infants as a modality to reduce apnea and respiratory depression. And till this date, this remains the gold standard to be used in this population for this indication. So let's see what are the indications which have been described in literature. The first and foremost is the premature infants who are born less than 35 weeks post-gestation. And any infant who is post-conceptional age of less than 45 weeks, especially those who are born preterm, but currently they are less than 45 weeks, because the apnea in this postoperative apnea, the incidence in this population is as high as 5%. Then if there is a past or current history of apnea of prematurity, which is required caffeine or methylxanthines, any chronic lung disease requiring home oxygen therapy, then significant history including intraventricular hemorrhage, necrotizing enterocolitis, ROP, any high-risk infant with congenital disease or airway anomalies, and any infant with absolute contraindications for GA. These all make indications for spinal anesthesia in preterm infants. These all, as you can see, any infant who is at high risk is a candidate for spinal anesthesia. So it has to be a very safe technique. But there are certain contraindications which we have to religiously follow, as it is there in the older population. These include coagulopathy, any thrombocytopenia, any local site infection, any non-communicating hydrocephalus, or allergy to the local anesthetics. So now let's see what are the benefits of using spinal anesthesia in this population. So first of all, we just need a very small drug, very small amount of drug, maybe 0.1 ml, to achieve a full surgical anesthesia. So it avoids a polypharmacy. So there is no postoperative respiratory depression. There is a very reduced need for opioid or no need for opioid, which leads to a very fast recovery, very fast OT turnover. So in turn, overall, it saves on the cost also. There is a decreased need for postoperative ventilatory support, even in high-risk population. Then there is a decreased PONV ILS, which will fasten the recovery. There is a very high hemodynamic stability in this population, which I'll be discussing why it is so in the subsequent slide. Then there is a recent ongoing concern of effect of anesthetic agents on the developing brain. So this is negated, and postoperative bleeding is also reduced. And then hypoxia, laryngospasm, bradycardia, all these have very low incidence. And definitely there is a markedly reduced stress response with the use of pure regional anesthesia with subarachnoid block. Now we are still, as of today, we are reluctant to use spinal anesthesia in children. It is very rarely used. So what is the reason for its underuse? It is mainly because we are fearful of any complication in this delicate, vulnerable age group. So there is a fear of adverse events. There is a lack of expertise because of disuse. So first of all, before talking about pediatric spinal anesthesia, especially neonatal and infant spinal anesthesia, we have to be aware of some anatomical and physiological differences. So dural sac, it terminates very low. So it terminates at S3 as compared to the adult spinal cord, which terminates at around the dural sac, which terminates at around S2. Then the spinal cord, it terminates in adult at L1. And in newborn, it terminates as low as L3 or L4. So what is the implication? We have to be very, very careful, and we have to avoid the lower end of the spinal cord. And so for that purpose, nowadays we have the assistance of ultrasound. We can use the ultrasound and we can avoid the lower end of the spinal cord. So this is a very important message here. But saving grace is that the two-fear line, which we use as a landmark in older kids and even adults, that passes low in these children. Why? Because the iliac blades, they are flatter. So in this population also, the two-fear line remains a reliable landmark, and it passes through L5S1 or L4L5. So it remains a reliable landmark. Then another important thing is that there is a very narrow subarachnoid space. So we need a very, very marked precision to achieve a successful block. Now, CSF is higher in infants. It is as much as 10 ml per kg in infants, in neonates, and 4 ml per kg, which is double of adults in older infants. Then CSF hydrostatic pressure is low. These in turn, this CSF low hydrostatic pressure and narrow CSF sac, this will lead to a reduction in the success rate of the spinal, which is well reported. This higher volume and the CSF, it is the more proportion of the CSF, it lies in the subarachnoid space as compared to the cranial cavity. So this in turn will lead to a greater dilution of the local anesthetic. Now meninges, they are very highly vascular and there is a higher cardiac output, which results in a very high and faster reabsorption of the local anesthetic injected in the CSF sac. So this in turn leads to a very short duration of spinal anesthesia, and it is not more than 55 minutes maximum in a neonate, beginning from 20 minutes. It may be as short as 20 minutes. So we have to be mindful of this, and we cannot use it for a complicated surgery. So there is a 5 times faster regression of motor block in infants, and a prolongation has been reported by the use of adrenaline as an adjuvant. Now, myelination is incomplete even till 12 years of age. So endoneurium is loose, so there is a faster onset and faster offset also of the block. Now, spine and ligament are less dense, so we may not be able to appreciate the loss of resistance. Spine flexibility limits the capillary spread. And lamina are cartilaginous, so we should be avoiding the paramedian approach. Now, coming to physiological changes, the hemodynamic suppression is minimal to absent. It is absent almost till 5 to 8 years of age because of various physiological changes. So no preloading is needed, and it is very, very safe. Even in congenital heart disease, it has been reported in last series. Now, respiratory system, though high-level blockade can be achieved with spinal anesthesia, but the outward motion of the ribcage may be reduced, and intercostal muscle activity may be reduced, and there may be paradoxical respiratory muscle movement. However, the diaphragm compensates for loss of ribcage contribution in most of the cases. So there is no respiratory depression in these children with spinal anesthesia. So now, what about preterm infant? It is a well-established and advocated technique in preterm infants, especially less than 6 months of age. And it is for a surgical procedure less than 90 minutes. Incidence of apnea, which has been reported, is as high as 30 to 40%, especially in infants less than 40 weeks of post-gestation. So what is the reason? There is certain population which is at high risk, that is children who are anemic, the neonates who have a hematocrit less than 30, post-conceptional age of less than 44 weeks, low birth weight, history of apnea, history of bronchopulmonary dysplasia, and any use of sedation or general anesthesia during spinal anesthesia can increase the risk. Now, there are various causes, including the immature respiratory musculature and immature cerebral system. So what are the equipments which will be required? We need a pediatric spinal needle preferably should be used because it has a low bevel and low needle dead space. Then if we are using ultrasound, we will be using a hockey stick probe. Then 1 ml spinal needle should be used. 1 ml this 1 ml syringe should be used for injection because the volume which will be injected may be as low as 0.1 ml. And Prilox may be needed for topicalization, though it is not licensed as of yet in infants less than 37 weeks. However, it is still reported and being used for even preterm infants. Now, a dose of drugs, most commonly used drug is bupivacaine in the dose of 0.5 to 1 mg per kg. Adjuvant, though they have been reported even in neonates, but they should generally be avoided. Patient preparation, the patient should be prepared as per general anesthesia guidelines. We have to prepare, we have to assess the child preoperatively, and we have to keep the child fasting as per general anesthesia recommendations. Then we should topicalize either by EMLA or by infiltration, local anesthetic infiltration. And we should choose and mark the puncture site at L4-5 or L5-S1. You can see the flat ileum. So the line, the two-finger line still passes at L4-5 or L5-S1, and we can use that. For keeping the child stable and comfortable, we can use a pacifier dipped in 20% dextrose and avoid any stimulus intraoperatively like loud noise and bright lights. We should avoid that. And Antonox has been reported like 50-50 nitrous oxide in oxygen for intraoperative and procedural sedation. Now, position is one very important aspect. So generally, we use a lying down lateral decubitus position. However, we have to be very mindful and we should be very careful of keeping the head extended, because any flexion in these children can lead to hypoxia. This has been reported. A decrease in transcutaneous oxygen concentration has been reported. Now, sitting position has the advantage that it increases the CSF hydrostatic pressure. So it will be advantageous in probably increasing the success rate of spinal anesthesia. Similarly, in sitting position, the head by the assistant is maintained in an extended position. And we should use a stillated needle because the use of hollow needle, which has been a practice in past, people have even used a hypodermic needle, but that can lead to dragging of the epidermoid tissue in the intrathecal space and later on formation of the epidermoid tumor. So now we can place the child in a lateral or sitting position. We see the free flow of the CSF and very gentle aspiration we apply, and we see the free aspirate, and then we inject. While using the drug, we have to be very careful, and we have to keep account for the dead space of the needle, dead space of the spinal needle, the hub and the needle. And then the child is placed, and then we can calm the child either by using a pacifier dipped in sucrose, or we can give some mild nitrous oxide 50-50 for keeping the child comfortable intraoperatively. In general, any kind of sedation should be avoided in very high risk ex-preterm infants to provide the maximum benefit to these children. And in my practice, I have seen that once we give spinal anesthesia, the spinal anesthesia induced deafferentiation keeps the child very, very comfortable intraoperatively. So intraoperatively, in general, we do not need any kind of sedation once the effect has set in. So drugs reported, the bupivacaine, ropivacaine, lipobupivacaine, all have been reported, whether hyperbaric or isobaric, they have been used in the concentration of 0.5% with an onset of 5 to 10 minutes and a duration only of 20 to 60 minutes maximum. So we may not be preferring a single shot technique for many complex procedures. So the drug which has been used for preterm infants, bupivacaine, it has been reported in dose of 0.6 to 1 mg per kg, that is 0.08 to 0.1 ml per kg, with an account of 0.1 to 0.2 ml for the dead space of the needle. So with ropivacaine, even a dose of 1.2 mg per kg has also been reported. Then Schenkman et al., they used 90%, they demonstrated a 90% success rate of spinal anesthesia by increasing the dose of using a higher dose, that is 1 mg per kg, bupivacaine, compared to 79% with a dose of 0.5 mg per kg. This, in fact, provided a good sedative effect, and most of the children did not need any kind of sedation with this dose. So how will we assess the block? The extent of the block can be assessed by use of nerve stimulator set at tetanus and or by a firm skin pinch, which we usually do. And generally, as soon as there is an onset of the motor block, the child's hip will fall apart, and we can easily see that the onset has taken place. Now, ultrasound guidance is coming up in big way in regional anesthesia, and same is true with the spinal anesthesia. And nowadays, I have started using even dynamic needling for spinal anesthesia in neonates and infants. So it is in fact much more easier than older infants or adults, because the vertebra, they are like cartilaginous and they provide very good acoustic window for entire spinal cord to be visible. So even if you are not using dynamic needling, we can check at the level and avoid the dural sac, avoid the dura, avoid the lower end of the spinal cord, sorry. So we should use both longitudinal and transverse view, check the level and avoid the lower end of the conus medullaris. So this is my past experience with spinal anesthesia. I have used it in generally for lower abdominal and lower limb surgeries. and for unilateral hernia, but once I even used it for bilateral hernia. But we have to be careful about the dose, and we have to be we have to know that the effect is likely to wear off in the end. So generally it is preferable, if you're using it for bilateral hernia, you can ask the surgeon to simultaneously start on both sides. So there are some concerns like technical difficulty, flailed block, limited duration, and need for sedatives, failure, total spinal. However, it is the main saving grace is that these all complications are very, very low and even negligible. So now coming to this present case, this is I will be discussing the anesthetic management of a gastroschisis repair in a 32-week preterm micropremy under spinal anesthesia. The child was only 930 grams. So the immediate repair of gastroschisis is crucial because there is a risk of sepsis. Micropremies are a greater challenge for anesthesiologists because all pediatric concerns are exaggerated. Spinal anesthesia can mitigate various potential risks like the risk of post-operative apnea, hemodynamic instability, etc. with the general anesthesia. There is additional risk factor like aspiration, hemodynamic instability, which are greater in gastroschisis children. So this was a 2-day-old preterm infant neonate who weighed 930 grams and was born at 32 weeks. This is the child. You can compare it, the sponge holding forceps with the baby size. So he was posted for partial reduction and silo bag application. He presented in AKI and he was shifted to the OT after adequate resuscitation. He was active cry. There was good cry and investigations were normal. So standard ASA monitoring was applied, and after taking precautions for hypothermia under aseptic precaution, spinal anesthesia was administered at as L4, L5 pace with 23 gauge Quincke needle and 0.5 mg of bupivacaine, that is 0.1 ml of bupivacaine. Then surgery surgery lasted for 55 minutes. As you can see, the vitals remained stable throughout the surgery. So this is the video. This is the subarachnoid block, which I could locate in first puncture. And after getting a free flow of CSF, using a 1 ml syringe, the injection was done. Then this is the child being. This is the video of the intraoperative video. The child was made supine. Then after painting and draping, the hemodynamics, as you can see, they remained very stable intraoperatively. We could not find any oxygen hood or suitable, nasal cannulas are also not available. So what I did was that I inverted a face mask, which was available, and it acted as a hood for this child. So this is the surgery ongoing. Now the surgery is over, and as you can see, don't miss the yawn. As you can see, the child, the motor block was still there, and child was very, very comfortable. So post-operatively, the child was shifted to NICU for observation for any respiratory distress, and the motor power was regained exactly at 90 minutes after the block, and post-operatively, rest of the stay was uneventful. So this is the past literature on gastroschisis. This was reported by Wayne et al., a series of 4 infants who underwent gastroschisis repair, and no complications were reported. Then this is a large registry from Vermont University, where they reported 1,500 cases, and out of them, 31 were gastroschisis, and they reported a birth weight from 500 grams to 7.8 kg. And in their series also, only 1.2% needed conversion to GA. So this is my review. If any of you want to go through the intricacies of pediatric spinal anesthesia in general or preterm spinal anesthesia in particular, all the intricacies are there. So to conclude, Spinal anesthesia in premature infant and neonates is associated with lower risk of bradycardia and apnea, hemodynamic stability, good immediate postoperative analgesia, excellent operative condition with good muscle relaxation, and very low incidence of complication. So I would like to conclude by saying that pain is inevitable, but suffering is optional. So we need to go an extra mile for these delicate, vulnerable preterm infants to assure the best outcome for them. Thank you very much. And this is my email ID. If any questions, they can be addressed to this. Am I audible?
Yes, you're audible.
Okay. Thank you. So we will move to the next presentation.
Good evening, everybody. And I'm Dr. Medha Kulkarni from Aurangabad. And at the outset, I would like to extend my best wishes on the occasion of World Regional Anesthesia and Pain Medicine Day, which is an initiative of the ESRA. And I would also like to thank the organizers for giving me this opportunity. And today I'm going to speak about segmental spinal anesthesia for breast surgeries. Now, in order to formulate the strategies for anesthesia for breast surgeries, we first need to know the innervation of the breast. So essentially, breast is a subcutaneous organ, and therefore it is innervated by the cutaneous branches of the intercostal nerves from T2 to T5 spinal nerves. So the lateral part is innervated by the lateral cutaneous nerves and branches, and the medial part is innervated by the anterior cutaneous nerves of the intercostal nerves from T2 to T5. The nipple areola complex is also innervated by both the lateral and the anterior cutaneous branches of T3 and T4, with maybe some contribution from T2 and T5. The other branches from the brachial plexus, which are the medial and the lateral pectoral nerves and the long thoracic and thoracodorsal nerves, do not directly innervate the breast tissue, but they innervate the underlying muscles, and these may be important in certain reconstructive breast surgeries or whenever some implants are to be inserted below the muscles. The common types of breast surgeries which we come across in our clinical practice are the excisional breast surgeries with mainly the fibroadenomas excision or lumpectomies or sector mastectomies, and CA breast surgeries, which are the modified radical mastectomies along with the axillary clearance. Other breast surgeries include reconstructive breast surgeries and cosmetic breast surgeries. So whenever we are formulating the strategies for anesthesia and analgesia for these breast surgeries, we need to set certain goals to provide surgical anesthesia and to provide immediate postoperative analgesia. So if we achieve these two things perfectly, we can really reduce the incidence of chronic post-surgical pain, which is very commonly associated with breast surgeries. Now, the predominant thing that we need to talk, which is the topic for today, is the neuraxial technique, which is in particular the spinal anesthesia, and that too a segmental spinal anesthesia. Other neuraxial techniques which are employed for breast surgeries include the epidural and the paravertebral blocks, and the other modality of anesthesia is the general anesthetic, along with a peripheral nerve block for analgesic purposes, which includes the intercostal nerve blocks and certain interfacial plane blocks like the erector spinae plane block or the PEX blocks. Now, here we are going to talk more about the spinal anesthesia, in particular, segmental spinal anesthesia. And for breast surgeries, we need to perform the spinal anesthetic at the level of T5 and T6 in order to achieve a segmental block for the breast surgery. And for this, we need to use an isobaric drug like levobupivacaine or ropivacaine, which may be used in the concentration of 0.75% or 0.5%. The local anesthetic volume required for performing a spinal anesthetic at the segmental level is very low, in the range of 1.2 to 1.4 mLs to achieve a sensory level right from T1 to T11. Additives can be used in order to prolong the duration of action of the spinal anesthetic and also to provide a prolonged postoperative analgesia. The commonly used additives includes the opioids like fentanyl and buprenorphine, which can be used safely, and also morphine, which has a slightly lower safety profile as compared to the other opioids. And hence, alpha-2 agonists have become very popular as additives in spinal anesthetics. And these include clonidine and dexmedetomidine, which may cause slight bradycardia and hypotension, which is easily treated with drugs like mefentermine. The other additives like ketamine, neostigmine, dexamethasone are not very popularly used because of their dubious safety profile and the fear of causing neurological toxicity. So now when it comes to technique, performing a spinal anesthetic at the thoracic level poses certain challenges, mainly because of the particular anatomy of the spine in the thoracic region, where the spinous process, as you can see here, are very steeply angulated and they overlap each other, providing a very little space for the insertion of the spinal needle into the intervertebral space. So if we are going by a midline approach, the angle of the needle needs to be really steeply placed in order to get into the interspinous space. And hence, it has been recommended that a paraspinous approach may be a bit easier to perform. But even in this, the needle needs to be angulated, and the recommended angulation in the upward direction is around 55 degrees to the long axis of the spinous process below. And this is along with an inward angulation of 10 to 15 degrees in order to reach the interspinous space into the intervertebral space. So this is a short video of the process of the procedure, and we have marked the spinous processes with reference to the inferior angle of scapula, which coincides with the T7 level, and the T5, T6, and T7 levels are marked, and we performed a spinal anesthetic at this level between T5 and T6 with a midline approach. The needle is advanced very carefully and gradually to obtain a free flow of cerebrospinal fluid and a local anesthetic. Here we used ropivacaine 0.75% and a total volume of 1.5 ml was given. Adequate level of anesthesia achieved and the surgery was done in an awake patient by using a spinal anesthetic as the sole anesthetic agent with a stable hemodynamics. And in the immediate postoperative period, you can see that the motor function of both the upper and the lower limbs are carefully preserved. So this is another patient. Both these patients have undergone modified radical mastectomy with axillary dissection. Again, here we have used a midline approach to achieve a free flow of cerebrospinal fluid. And in this patient, we used levobupivacaine 0.5% isobaric drug along with fentanyl 10 micrograms. The level of anesthesia is checked with a pinprick, and the surgery was performed along with the axillary dissection in this awake patient successfully. Again, the hemodynamics were absolutely stable during the entire procedure. Lot of benefits are associated with a thoracic spinal anesthesia. The most important in that being the stable hemodynamics, probably because of the segmental sympathetic block which we are providing with a thoracic spinal using an isobaric drug. The lower limb function is preserved, and hence it offers very stable hemodynamics. There's hardly any respiratory compromise. The patients are able to breathe freely. Spinal anesthesia has already been shown to reduce drastically the neuroendocrine stress response. The incidence of postoperative nausea vomiting is significantly lower in patients who received thoracic spinal anesthesia, as shown in this study by N. Paliwal and his colleagues. And they compared it with GA, with a general anesthetic, where they found it to be 25% as compared to 3.75% in thoracic spinal anesthesia. So it was very significantly reduced in the so offering a better profile, safety profile. It also offers better intra and postoperative pain control, which is very important for preventing chronic post-surgical pain. There was early return of gastrointestinal function, so reduces the incidence of paralytic ileus in the postoperative period. Hardly any urinary retention observed in these patients. And since we preserve the lower lower limb function, the patients can be ambulated earlier, and this can result in early discharge from the hospital. Certain concerns have been raised with respect to a thoracic spinal anesthesia. The most important and among them being the spinal cord injury, about which I'll speak in the next slide. The incidence of paresthesia is nearly 6% with a low thoracic spinal anesthesia, and this is comparable to that with in the lumbar and cervical region. And these are not associated with any long-term neurological deficits. There is a possibility of inadequate ventilation, but this is ruled out since even though the intercostal muscles are paralyzed because of spinal, the main muscle of respiration, that is the diaphragm, is intact, and so the patients might feel some degree of heaviness in the chest because of an impaired respiration, but it is not very troublesome, and a mild sedation can take care of that. It does require a longer learning curve, and yes, that is why this technique is not for novices, and it has to be done by skilled and senior anesthesiologists. So that is one important thing. Now, as I said, the fear of spinal cord injury was addressed by Imbelloni and their colleagues, and they performed this MRI study. And a similar study was performed by Zundert and their colleagues, and both of them came to the same conclusion, that the spinal cord in the thoracic region, probably because of the peculiar curve of the thoracic spine, lies at a distance of nearly 5.4 to 5.7 millimeters from the posterior dura. So that is quite a long distance, and hence the incidence of injury to the spinal cord in this region is almost nil. as this distance is even more as compared to the cervical and the lumbar region. And this study was done in a supine position. So when we are performing a spinal anesthetic, we are doing it in a sitting position, which will even further make the spinal cord fall anteriorly, increasing the distance between the spinal cord and the posterior dura. So that makes this procedure quite a safe one with respect to the spinal cord. Now, considering the other modalities of anesthesia for the breast surgeries, let us compare it with the epidural. Now, epidural anesthesia involves a very high volume of local anesthetic as compared to a spinal anesthesia. The risk of dural puncture is always there with epidural anesthesia, and here we are using a large bore needle, and it is causing a dural puncture with that large bore needle might result in a higher incidence of post-dural puncture headache. Also, when we place catheters in the epidural space, there is a risk of migration of the epidural catheters, resulting in accidental intrathecal injection of large volume of local anesthetic, resulting in a total spinal anesthesia probably with very catastrophic consequences. Paravertebral block has gained a lot of popularity, maybe because of the ease of administration, and it does not require any special gadgets like ultrasound, can be performed with loss of resistance. Probably that is the reason it gained a lot of popularity, but it involves multiple pricks at different levels in order to get a complete analgesia of all the segments, and sometimes a bilateral block may be required. So thus, it also involves a large volume of local anesthetic drug. And in addition to this, still the action of the paravertebral block may be unpredictable. It may be a patchy action. There may be a medial spread into the epidural space. And most importantly, there is a risk of pleural puncture due to the close proximity of the pleura to the paravertebral space. And this may even result in a pneumothorax. Coming to the interfacial plane blocks, these are the various interfacial plane blocks, but they cannot be used as a sole anesthetic as their action is quite unpredictable, and they have to be used along with a general anesthetic. And thus it will come along with the all the disadvantages which are associated with a general anesthetic. So they may provide analgesia, but as a sole anesthetic technique, they are not suitable. Now the segmental spinal anesthesia is not completely devoid of any pitfalls. So to carry out this procedure in a very safe and successful manner, we need to actually very carefully and thoroughly evaluate the patients in the preoperative period, and select the patients, categorize the patients and select the patients for carrying out the surgery in thoracic spinal. The indication for thoracic spinal must match the surgical needs of the patient. So we need to judiciously administer thoracic spinal at a particular level where it will cover the particular segments which will be involved in that particular surgery. This technique is to be reserved for experienced anesthesiologists with a good learning curve, and novices should defer from performing this procedure, and also this, like students. And to establish the safety of thoracic spinal anesthesia, lot more randomized controlled trials need to be performed, so that because the documentation with respect to these this procedure still lacks that kind of credibility, and hence we need to perform more RCTs. Thus, to conclude, thoracic spinal anesthesia, it is a safe and effective anesthetic modality for breast surgeries and can be used as a sole anesthetic with a low volume of local anesthetic. It does provide a high quality intra and post-operative analgesia. It preserves the motor function of the lower limbs and hence reduces the length of hospitalization with a better patient satisfaction, and most importantly, prevents the incidence of chronic post-surgical pain. Thank you.
Thank you very much, Dr. Medha, for your wonderful talk on awake breast surgery. So, segmental spinal anesthesia is indeed come a long way, and we need to keep ourselves abreast with the update in this regional anesthesia for keep providing safe anesthesia to moribund patients. Now, ladies and gentlemen, we are absolutely honored to have the president of ISRA, Dr. Eleni Moka, join us today. So warm greetings on second World Regional Anesthesia Day and Patient Management Day, Dr. Eleni. And I would like to invite you for sharing some words of wisdom with our audience. Welcome. Welcome. Thank you for joining us.
Hello, can you hear me well? Because I'm in a fully busy center in Paris. I hope you can
we can hear you very well.
Okay, fantastic. Thank you very much for inviting me and for the very kind introduction by Dr. Anju Gupta. Congratulations to all of you and happy World Day of Regional Anesthesia and Pain Medicine. We are all very excited and we feel privileged to have you on board, your country, your center, as far as, and also many other cities and countries. We reached 200 cities across 80 countries in all continents, which is a fantastic shout on the benefits of regional anesthesia. Just now I learned that I was calculating and saying, okay, maybe 20,000 participants, probably we will exceed 55,000 worldwide, which is a great result. Thanks to all the sister societies that have contributed in making this event a reality. Thanks also to all national societies and all speakers and attendees. I believe that the message I would like to transfer to all of you is that there are no borders, there are no barriers at all, even if we have distances geographically speaking. Education, training, knowledge spread have no barriers, and we have managed all together to cross any boundaries that exist, because if we act alone, we may go fast, but if we act all together, we can go far. Happy World Day of Regional Anesthesia, and let's make practice and reality what our theme is. Let's join our hands for a pain-free future worldwide. Thanks a lot to all of you from my heart.
Thank you so much, Dr. Eleni, for sparing your valuable time for us. And the celebrations are indeed looking magnificent. And many congratulations to you and your team for such wonderful initiative. Thank you very much.
Thank you. Bye-bye.
Thank you. So now I would like to invite the next speaker, Dr. Ofelia Grimaud. So Dr. Ofelia will be speaking on awake spine surgeries. And Dr. Ofelia is she has trained and graduated in anesthesia and intensive care in Paris. She is continuing private practice in southeast of France, and basically she has gained experience in central blocks and regional. She has introduced regional anesthesia to countries of Eastern Europe, and she is an active member of ISRA since 1991. And she has delivered talks and abstracts and presented abstracts and participated in workshops at ISRA, European Society of Anesthesia, AORA congresses. So warm welcome to Dr. Ofelia, and I invite her to deliver her talk on awake spine surgery. Welcome, Dr. Ofelia. You can please start your talk.
Dear colleagues, I am Ophélie Grimaud, consultant anesthetist in France. It's a honor for me to be part of your meeting today. Sandeep Diwan invited me to show the different aspects of the thoracic segmental spinal as an indication for spine surgery.
Segmental thoracic spinal procedure was performed and presented already by Hubbard in 1950. He realized lateral thoracotomy without motor block for the lower extremities. In 2006 and 2007, Van Zundert documented the performance of T10 segmental spinal cholecystectomy using the combined spinal epidural technique. Between 1995 and 2008, Signa et al. Made a retrospective analysis on 4,645 patients describing various laparoscopic surgeries under thoracic spinal. The authors concluded that there are several significant advantages for the patients who received spinal anesthesia, like hemodynamic stability, decrease in the requirement of postoperative analgesia, less postoperative nausea and vomiting, as well as rapid recovery and discharge. Thoracic spinal could be performed for breast cancer surgery, elective or emergency abdominal surgery by laparoscopy or laparotomy for cancer in frail patients or contraindicated to general anesthesia, cardiac surgery, lung surgery, thoracic spine surgery, and thoracic traumatology, as well as chronic pain therapy for terminal cancer pain. Spine surgery can be performed under spinal anesthesia at lumbar and thoracic level with patient awake, mostly by posterior approach. Different pathologies can be treated, like scoliosis in young adults and teenagers. It may consist of vertebral arthrodesis, but in severe cases, spinal fusion with Hutchinson's stem could be necessary. Other indications are post-traumatic canal stenosis, dorsal kyphosis, kyphoplasty or vertebroplasty for thoracic spinal fractures, which represent many invasive procedures. The technique of thoracic spinal anesthesia is special and adapted to the anatomy of the thoracic level. The distance between the skin surface and the ligamentum flavum is variable between 2 and 4 centimeters. The thickness of the ligamentum flavum is between 2 and 4 millimeters. The epidural space is situated between the ligamentum flavum and the dura mater, and at this level it has less than 1 centimeter depth. The distance between the dura mater and the spinal cord represents the subarachnoid space. The depth of the posterior subarachnoid space is variable, estimated by Lee and Imbelloni, largest at T6 and T5 level. The intracecal space situated posterior to the spinal cord becomes larger in forced thoracic flexion. When performing thoracic spinal, the patient should be positioned in lateral decubitus and forced thoracic flexion. The best choice for the level of puncture is T5-T6 by median approach. The angulation of the needle depends on the level of puncture. During surgery, the patient is in prone position. Different techniques and devices are available. The standalone spinal approach is more challenging and represents a higher level of danger, because it is more difficult to locate all the ligaments and gaps preceding spinal cord using an ultrafine gauge spinal needle. In elderly individuals who have altered tissue elasticity, spondylarthrosis, or poor amount of CSF flow. On the other hand, standalone spinal may not provide total coverage of surgery or the possibility to enhance the surgical level required by the procedure. Standalone spinal approach doesn't give the possibility of opioid-free postoperative pain management, but it could be a very good option for short invasive procedures like kyphoplasty, vertebroplasty in young patients. The combined spinal epidural technique provides total control of the procedure per and post-operatively with minimal risk of spinal cord injury using a 27-gauge 123 mm Quincke spinal needle, an ultra-soft tip epidural catheter, aero epidural catheter. The epidural space is identified by the loss of the resistance to air technique and by median approach. The operative protocol consists of a spinal dose of 1 milliliter isobaric bupivacaine 0.5 plus 1 milliliter of fentanyl or fentanyl. Postoperative analgesia is supplied by epidural catheter with bolus on demand, consisting of 10 milliliters isobaric bupivacaine 0.125 or ropivacaine 0.2 and 1 milligram morphine. Continuous spinal anesthesia consists of introducing a catheter into the subarachnoid space. There are two types of catheters. The catheter over the needle is the Wiley spinal. It is a flexible intracecal 23-gauge catheter introduced over a 27-gauge spinal needle through a pilloway sheet over a standard 18-gauge TOE needle. After local anesthesia, the epidural space is identified by the loss of resistance to air and by median approach. Then insert an advanced Wiley spinal until dural click is detected. Then advance flexible cannula to pilloway hub. The spinal needle is removed and the flexible cannula is advanced intrasecally by separating the pilloway to patient skin. After first spinal dose injection, insert weak wire and secure Luer lock connection. The second type of catheter is through the needle. The Payung Intralong is an ultrafine 27 or 25 gauge spinal catheter needing a metallic guide to be introduced through a 22 or 21 gauge Quincke spinal needle. The metallic guide of the catheter and the 21 or 22 gauge Quincke spinal needle represent a risk of spinal injury. The difference of gauge between the spinal catheter and the Quincke spinal needle facilitate an important leakage of CSF with high rate of PDPH in patients younger than 70 years. Another option for using the catheter through the needle is the Aero Epidural FlexTip Plus. A 21 gauge catheter is introduced intrasecally through a 19 gauge TOE needle. After detection of the epidural space, by the loss of the resistance to air technique and of the DuraTap by a fine popping feel. And after CSF leakage through the theory, the ultra-soft tip catheter is easily introduced 3-4 centimeters beyond the needle. The advantage of using Aeroflex Tip Plus catheter is to eliminate the incidence of vein cannulation and to effectively reduce the incidence of paresthesia. PDPH can be avoided by leaving the catheter 48 hours in order to facilitate an inflammatory reaction, and also by injecting in the epidural space 10 milliliters of a colloid solution before catheter removal. The perioperative protocol consists of a spinal dose of 1 milliliter isobaric bupivacaine 0.5 and 1 milliliter sufentanil or fentanyl. Postoperative analgesia by spinal route consists of a 1 milliliter bupivacaine 0.125 or ropivacaine 0.2 plus 0.1 milligram morphine into 1 milliliter saline. The total volume is 2 milliliters. In order to exclude a needle being within the spinal cord, you should use a soft tip catheter. If introduced easily, it is in one of these three places: intracecal, epidural, intravenous, but not within the spinal cord. For security reasons, an aspiration test has to be done through the needle or the catheter. The test dose is necessary only if the catheter is placed epidurally. The advantages of thoracic spinal for this type of surgery are very important. Since the patient is awake, he can cooperate with the surgeon. Since there is no motor block of the lower limbs, the movements are preserved, and the surgeon can and must verify if any perioperative injury of the spinal cord. The hemodynamic effects are minor, and it is possible to provide excellent postoperative pain relief by intracecal or epidural catheter. The prone position and generally long procedures made the patient feel uncomfortable. In elderly patients with deforming pathologies of the spine, technical difficulties may be encountered, leading to failure. Spine surgery is a delicate and invasive procedure requiring patients' cooperation and efficient postoperative analgesia. For this reason, segmental thoracic spinal anesthesia and analgesia represents the solution of choice, especially in teenagers undergoing laborious surgery for scoliosis. But in the same time, this technique requires great care since accidental medullary puncture is possible, leading to transient or definitive neurological sequelae like paraplegia, quadriplegia, death. On the other hand, if large volume and high concentration of local anesthetic is injected, a high spinal block can occur with acute ventilation failure, bradycardia, hypertension, requiring immediate cardiorespiratory support. The segmental thoracic spinal for spine surgery is technically feasible, practiced effectively and safely by a good number of experienced anesthesiologists accustomed with accurate execution of neuraxial blocks. the immediate outcome of the patient is excellent. But the major concern remains the spinal cord injury due to the needle penetration of the cord or of an intracord injection. Thank you very much for your attention.
Thank you, Dr. Ofelia, for your excellent talk. You have covered all the intricacies of awake spine surgery very well, and we were honored to have you. Next in the line of awake spinals is Dr. Priyanka. Dr. Sangadala Priyanka will be talking on continuous thoracic spinal. She has done her MD from AIMS Rishikesh, and her dissertation topic was continuous thoracic spinal only under Dr. Praveen Talwar. So I think she will be the appropriate person for this talk. She is currently pursuing her pain fellowship in AIMS Jodhpur, and she has 10 international publications. Welcome, Dr. Priyanka.
Thank you, ma'am. Thank you so much for the kind words. And thank you, the organizing team, for giving me this golden opportunity. Let's start our talk. I've done a study. It is a randomized controlled trial. It is a double-blinded study on comparison of block characteristics and outcomes in opioid-free and opioid-based, and it is done in a major abdominal surgery through continuous thoracic spinal anesthesia. I have concentrated mostly the talk on the practical aspects of the procedure rather than diving into the theoretical aspects of the study. So to conduct this continuous thoracic spinal anesthesia, we have used this pudging CSA set, which usually contains the blood lancet, and we have 21 gauze special spotted tip spinal needle, and we also have 25 gauze spinal catheter in this, and we also have the clamping adapter with the filter. In this video, I'll be telling you how to use the procedure through a video basis. For this study, we have kept the inclusion criteria of age more than 18 years and of ASA category 1 to 3. And for the exclusion criteria, same as the exclusion criteria for any spinal anesthesia. Patient refusal, any coagulation abnormalities, hemodynamic instability which is present prior to the surgery, and any local site infections. So in the pre-procedure workup, we will do a regular workup as we do for any surgery. And written informed consent is very critical. Patient consent is very important because it is a major abdominal surgery which will be carried out for more than 4 hours, for sometimes even to 8 to 10 hours. And patient will be completely awake and patient will be supine. So patient cooperation and understanding is very important for this study, and pre-anesthetic workup we will do as for the regular study. So I'll be explaining you the procedure and later I'll be showing you the video. Because it's a major abdominal surgery, I'll be requiring T4 to L1 anesthesia levels. So for that, I have chosen T10 to T11 intervertebral space. I'll make the markings and I'll clean, drape, and because sterility is the key. After draping and marking the sites, we will give a local infiltration at T10, T11 level, intervertebral space, and then we will be using the blood lancet to give a nick. Why should we use this blood lancet? Because the 21 gauze special spotted tip, it's blunt. So it is difficult to introduce the spinal needle through this blunt tip. So we'll be using this blood lancet to give a little bit of nick at the desired space, and through this we'll be introducing our 21 gauze special spotted tip needle. Once we introduce the needle till we get the free flow of CSF. Once the free flow of CSF is confirmed, we'll remove the stillet and then we'll reintroduce this 25 gauze spinal catheter. How much should we introduce it? Because the length of the spinal needle is 9 centimeters. For suppose if we got at 6 centimeters level, we will introduce this catheter 3 to 4 centimeters beyond the tip where we have achieved this free flow. So for suppose if we have received at 6 centimeters, 3 to 4 centimeters, so we will keep this catheter 10 centimeters at the skin level. So once we have introduced the catheter beyond 20 centimeters and we remove this end-to-toe spinal needle and the catheter out till the desired amount at the skin level is achieved. Once we remove this entire thing out, this spinal catheter has a very minute guide wire in this. We will remove this guide wire until the skin level, and then we'll secure it. I'll show you through this video, starting from this beginning. I've cleanly draped and pointed it out, and we are going for local infiltration, and now I'm going for lancet. Yes, I'm introducing the spinal needle till this free flow of CSF is achieved. Once the free flow of CSF is confirmed, I'll be removing the stillet. You can see here, I'm removing the stillet out. Now I'm introducing this 25 gauge spinal catheter into it. We'll introduce the 20 centimeters marking is completely in to confirm the spinal space. Now I'm removing this end-toto needle and the catheter till the skin level. Once it has reached the desired skin level, yes, I'm removing it. You can see in this video. Now I'm removing slowly the very minute guide wire through it. Once I'm removing the guide wire, I'll be reconfirming the free CSF flow. And then now, after removing this end-toto thing, I'll be attaching it to the clamping catheter adapter with the filter. Now I have to pause this video, and I want to explain you. When we were doing this study, we did not think of giving the subcutaneous tunneling. But when we were observing patients where there was poor post-operative pain relief, in the retrospectively, we have analyzed that there was kinking of the catheter at the skin level. To avoid this kinking of the catheter, we have started this subcutaneous tunneling. And once the study progressed, we have even observed that the catheter got kinked even at the skin level when we were attaching. So we have started even using the sterile suction catheter and cut it to the desired level, desired length, and then reintroduce this spinal catheter into the suction catheter. I'll be showing you in this video. Once attached, I'm reintroducing this spinal catheter to the suction catheter, which is sterile, and I'm confirming and attaching it very well to the skin level through double plaster technique. And now I'll be making the patient supine. See, when you observe, I have not given any drug till now. I have not given any drug, but I make sure that entire sterility has been achieved in this entire procedure. Now I'll go further for giving drug. So why did I choose only supine position for giving drug? Because the drug I have used in the study was 0.5% hyperbaric bupivacaine, and have used intrathecal fentanyl. To avoid high spinal, as it is not isobaric, we have chosen the supine position. We have not given any drug till now. So once we have achieved all this, we have done all these techniques and we made the patient supine. Now I'll administer the drug. As I've told, the study is opioid based and opioid free. In the opioid based group, we will be giving intrathecal fentanyl 0.3 mics per kg, and we'll be using 0.5% hyperbaric bupivacaine in graded doses. First, we'll be giving 0.5 ml of 0.5% hyperbaric bupivacaine, that is 2.5 mg of bupivacaine in the graded doses. Once we give 0.5 ml, we'll wait for 3 minutes and we'll reassess the level. Again, we'll give graded doses. We have seen in most of the cases, we have conducted 50 to 60 cases. In most of the cases, we have seen 2 to 2.5 ml of drug was sufficient to achieve the spinal anesthesia level from T4 to L1. We will check this T4 to L1 level through pinprick, touch and cold sensations. And once this level of anesthesia is achieved, we will note how much amount of drug was required to achieve this T4 to L1 level. For suppose if the patient required 2 ml of drug, and along with that 0.3 mics per kg of intrathecal fentanyl, we will calculate this. And we had a plan of giving bolus drugs, but again, sterility is a concern. We have to be sterile at every step, every hour. It is very difficult to maintain. Keeping sterility at mind, we have started using continuous intrathecal infusions. Now you will get it out how much hour we have to calculate and how many hours we have to calculate this dose. For suppose if the surgery is planned for 6 hours, but we'll take it for 8 hours as a prophylactic thing. We'll calculate the drug 2 ml per hour for 8 hours, that would be 16 ml. We'll load that syringe with the 16 ml and we will give through the infusion pump 2 ml per hour, along with that 0.3 mics per kg of fentanyl every hour. Through this drug, we used to maintain T4 to L1 anesthesia levels. If there is any regression of segments, either 1 to 2 segments regression, we used to give bolus doses of the intrathecal bupivacaine. that is 2 ml per hour dose, which was required to achieve T4 to L1. We used to give this bolus doses of the drug. So many people ask me, so you have started continuous intrathecal infusions, and what if there is inadequate analgesia? Inadequate analgesia, we will reassess the levels. We will give bolus doses of intrathecal drug, and we also go for rescue fentanyl, IV rescue fentanyl. Even with this, if there is a VAS score of more than 4, then we would take a call for conversion to GA. So patient consent is very important. While you're taking consent, please do explain patient even about GA. Take consent even for GA. And for suppose, see, not every surgery goes as planned. Many people ask me, are there any conversion rates to GA? Technical issues were there while initially starting this procedure. There was kinking of the catheter. So if there was inadequate anesthesia levels, or if there are any surgical considerations, massive blood loss intraoperatively, if there was very difficult to maintain hemodynamic instability, then conversion to GA call can be taken. So now coming to the practical constraints which we have faced while doing this procedure, complete sterility is a must, and patient cooperation, and many anesthetists are even feared to give thoracic spinal anesthesia at thoracic level. But Megha ma'am has clearly explained and even discussed about the many studies which have shown its feasibility and safety concerns. And as I've said, in the practical constraints, there was threading of the catheter was a difficulty, and there was dislodgement. To prevent that, we have used subcutaneous tunneling, and we have even used the sterile suction catheter to prevent kinking. And intraoperative hemodynamic instability was the biggest concern, because as we know, spinal anesthesia itself causes hypotension. To prevent this, we used to go for preloading and co-loading of the patient very well in order to avoid this sudden hypotension. And we used to keep a map of more than 60 or more mm of Hg. To maintain this, along with preloading, co-loading, we used to go for mefentramin bolus doses of 3 to 6 mg. And if multiple doses of mefentramin occurs, and then we have to go for low dose NORAD infusion. So how do we go for this intraoperative monitoring? We'll go for all standard ASA monitors and intraoperative continuous intrathecal infusion, as I've said, and hemodynamic instability have to be monitored, and blood loss is a concern, and adequate IV fluid administration need to be kept in mind. So once the surgery is going well, and we have checking the levels of T4 to L1 anesthesia, all good to go. And once we have surgery is done, see, because the patient is supine and he's awake. So we can go for intraoperative mild sedation using intravenous midazolam 0.02 to 0.05 mg per kg. And even you can go for intravenous ketamine 0.5 mg per kg in a graded doses. And to maintain intraoperative sedation, we can go for dexmedetomidine infusion as well. So once the surgery is done, if half an hour before the surgery, stop the dexmedetomidine infusion, and even stop the intrathecal infusion which is going on. So now everyone asks me, yes, Dr. Priyanka, you have done intraoperative management well. And what about the postoperative analgesia? You have kept the catheter inside, it's in the intrathecal space. How are you going to manage the postoperative pain? I can't go and give the drug all boluses, because sterility is a concern, because patient would be shifted to ward at that time. So, and at the same time, I want continuous analgesia even in the postoperative period. So we have chosen the elastomeric pump to give postoperative analgesia. So as I've said, in our study, we had two groups, opioid-free and opioid-based group. In the opioid-based group, we have taken intrathecal fentanyl, and we have used preservative-free lignocaine. The concentration of the preservative-free lignocaine, it's 0.2%, and the fentanyl should be 2 mics per ml in each ml of the solution which we have prepared. And we used to load this into this elastomeric pump, and we used to set the ml per hour rate. Because this postoperative intrathecal elastomeric pump was used for 72 hours. Because no need to remove and reinsert, and sterility issues will be solved, we will load this drug in the intraoperative, and we'll attach once the surgery is done. We will assess the levels of the analgesia and anesthesia still left. Once the T4 L1 levels are regressing, we will connect this postoperative elastomeric pump to the patient. And you see, in the immediate 24 hours of the postoperative period, we have used 4 ml per hour, and the next consecutive 48 hours, we have used 2 ml per hour. In this elastomeric pump, we have the feasibility of setting the rate. So everyone would ask, what if the patient himself will increase the rate or decrease the rate, or surgeon in the ward in the pain concern, he might increase or decrease the rate. But if you see, there is a key for it, and only the anesthetist used to carry this key, and we used to set the lock. Only with the key we used to make the adjustment. So even this concerns are solved, and we have monitored the patient like this for 72 hours. So even if with this the pain was not well controlled, then we used to go for rescue IV fentanyl or even intravenous paracetamol if the VAS scores are more than 4. So in the opioid group, we have even observed the postoperative nausea and vomiting is very high, but the patient pain management was very well controlled with this technique. So even I want you to discuss the practical constraints which we have observed in the intraoperative period. As major abdominal surgery was going on, rise tube insertion intraoperatively, we have seen failure of the procedure because of the patient not being so cooperative intraop. So we have started inserting rise tube with the consent from the patient in the pre-op itself to avoid this intraoperative complications and intraoperative cooperative issues. And we have also seen, we have also used the post-operative oxygen mask is must for first 24 hours because of the dexmedetomidine infusion, which was usually a concern in the post-operative period. So if there is any intraoperative conversion to GA, but we have introduced the spinal catheter. So to avoid PDPH, we used to keep this intrathecal catheter for 48 hours, 24 to 48 hours to avoid PDPH. So my take-home message on continuous thoracic spinal anesthesia, can be considered on when patients who have major post-operative concerns and who have many respiratory complications, and after major abdominal surgery, because of the respiratory complication, because of the long duration of surgery where patients will land up in ICU and mechanical ventilation. Trust me, of the 50 to 60 patients we have done study, we have not seen a single patient getting admitted to ICU because of the respiratory compromise or because of the anesthesia concerns. And we have even decreased the respiratory compromise, no ICU admission, better pain control was there, and we have reduced DVT concerns, and early return of GI mobility was there, as all the benefits of spinal anesthesia were also seen in this. So I want to even inform you, by attaching the elastomeric pump, there will not be any difficulty for mobilization because it comes with a clip which can be attached to the patient clothes, and you can even advise the early mobility after the post-op, so with a better pain management. Thank you for giving me this opportunity. If you have any issues, you can reach me through the mail. Thank you.
Thank you, Dr. Priyanka, for your excellent talk. You covered all the intricacies of thoracic continuous spinal anesthesia as expected. Now we are done with the segment on high spinals. Before we proceed to the site-specific surgery, I would like to address the questions for the first segment on high spinals. So I would invite Dr. Medha to please address these questions. You have been bombarded by a lot of questions from the audience. Dr. Medha, are you here?
Yes, I'm here.
Yeah, okay. So the first
I hope I'm audible.
Yeah, you are very well audible. You are,
okay.
Yeah. So first question is from Dr. Naresh Paliwal. We are honored to have you, sir. He is the master of segmental spinal.
Yes.
So, yeah. So his first question is that is level from T1 sufficient for surgery like MRM? It should be C5 to T7 at least. And how do you test motor block at cervical and high thoracic level? So, Dr. Medha, you have already addressed this question, but
yes.
I would like you to briefly tell it to others for the benefit of other delegates.
Yes, sure. First of all, a very good evening to Dr. Naresh Paliwal, sir. Sir, you are the boss actually of segmental spinal, but still, yes, I'll answer your question. Up till now, whatever MRMs I have done with a segmental spinal, I did not encounter a lot of discomfort amongst the patients, and whatever little discomfort was there at the time of axillary dissection, in a couple of patients, a mild sedation with, say, fentanyl and midazolam was sufficient to take care of it. Considering your second question, for breast surgeries, it's quite a superficial surgery, so I don't think that you really need to test any motor action. So a sensory block is like sufficient for it.
Okay. So
Is
I
that
hope
okay?
that satisfies Dr. Naresh Paliwal's query. Now, another question from Dr. Naresh Paliwal is that how about giving single shot spinal directly in prone position using isobaric drug and dexmedetomidine as additive for longer duration ESPB for postoperative analgesia? So basically, he's asking about giving a single shot spinal in prone position using isobaric drug and dexmedetomidine as an additive for prolonging the duration of anesthesia, along with the addition of an rectus spinae plane block for postoperative analgesia.
I guess, Dr. Anju, this question is for Dr. Ofelia, because
Okay,
he
okay,
wants
yeah,
to give it in.
yeah, you are right. You are right.
Yeah.
I thought he has addressed all the questions to you.
Yeah, I think those were the only two questions for me, I guess.
Yeah. So now I would invite Dr. Ofelia, please, to address this question of Dr. Naresh Paliwal. Dr. Ofelia, are you with us? Dr.
Yes,
Ofelia?
definitely.
Yeah.
Yes,
Welcome,
I'm with
ma'am.
you. Yeah.
Welcome, Dr. Ofelia. And
Thank you. Thank you very much. So I'm listening.
Yeah. So could you get the question? Should I repeat it?
If I have a question?
Yeah, there is one question for you. There is one question for you. So
yes,
the question is from Dr. Naresh Paliwal about, he is asking how about giving a single shot spinal directly in prone position using isobaric drug and dexmedetomidine as an additive for longer duration and adding rectus spinae plane block for postoperative analgesia. So what is your take on that, ma'am?
My idea, according to my experience, is that nothing is better than a catheter to control per and postoperatively. If you make I prefer to use lower doses for the first shot and make a kind of even if I have to inject again, I may do it via the catheter. And also for longer procedures, as I say, you can control the level of your sensitive block and the duration. This is a big advantage of a catheter. And another one, very important, is the postoperative pain management for analgesia. So with lower doses, you can titrate. You have all the advantages using a catheter, really all the advantages. Single shot could be a little bit stress for the anesthetist if something happens and you cannot control with a standalone spinal dose.
Very well, Dr. Ofelia. I hope that satisfies Dr. Paliwal's concern. Now, there is another question from Dr. Paliwal himself. While giving fast dose and repeat dose, did you take into account the dead space of adapter, filter, and catheter, which is around 0.9 ml for PEJUNC?
Of course, you have to count all the milliliters you inject, and you have to. You should know that you lose. You have 1 milliliter volume along the catheters, the catheter and the filter. So you have to calculate these two. But you only inject if you need. If the duration of the surgery is more than 2 hours. But you can be very happy because you can control everything. And I think this is a point. You have to control all the time the perioperative and the postoperative period. and you do it with a catheter. Catheter is magic, on my opinion.
Yeah, I can see that. So another question by Dr. Divesh is that, do you insert thoracic catheters, continuous spinal anesthesia for lumbar spine surgery? And do you direct the catheter caudally?
And if I do what? And I do, no,
You direct
I
them
don't have to.
caudally.
No, for lumbar spine surgery, I do the same technique, but I do the puncture at L1, L2. This is the level L2, L3, and I also I forgot to specify that for the surgeon's comfort, I put the catheter, I tunnel the catheter. So the surgeon can operate, or sometimes that depends of the surgeons. If they don't want me to leave the catheter during the procedure, I give them the catheter, and at the end of the procedure, they put the catheter and we tunnel, and he tunnels it. But I always have a catheter postoperatively.
Okay. Thank you, Dr. Ofelia. I think that concludes your questions. Now, I would like to ask Dr. Thoracic Segmental Spinal. Yeah. So, Dr. Priyanka, are you there?
Ma'am, I'm there.
Yeah. So, there are some questions for you. Dr. Jyoti has asked, there are some issues mainly on the availability of spinocath, cost, affordability, sterility issues, and safety issues. So what is your take on that?
The Pajung set availability, it's really concerned, but if you're ordering for a bulk of things, it can be available. When cost issues, if you think the cost of a GA case will be much more when you see the cost of a spinal case, which we usually do a major abdominal surgery. And sterility is a must thing to be followed, because meningitis can be happening. If sterility, if you're not able to maintain intra-op or the post-operative, then better don't consider trying this continuous spinal anesthesia. If you can maintain sterility and well monitored in the intra-op and post-operative, then only you can consider for using this continuous spinal anesthesia catheter.
Okay.
Safety, when coming to the safety issues, many people are afraid of high spinal, but we have not seen any high spinal in our study, because the reason might be because we are giving the drug in a very graded doses. We are not giving drug all of a sudden. We are giving drug in a very graded doses, and we are checking every 3 minutes till the adequate spinal anesthesia levels are achieved only from T4 to L1, not beyond T3. So once if we give the drug in a graded doses, you can avoid it. Even if any high spinal occurs, we have GA procedures to be done all ready with us, and you can even aspirate the drug because we have a spinal catheter in situ. So I think this answers their query.
Yeah. So we have another question for Dr. Medha. Dr. Medha, are you still here?
Yes, I am there.
So what is the gauge of spinal needle which should be used for segmental spinal anesthesia for breast surgery? I think you mentioned that in
Yes, I have. Yes, I mentioned it. I use a 25 gauge Quinky needle.
Okay. And this is another question on spinocath. 18 gauge epidural catheter. Dr. Rajesh has a comment that he has been using 18 gauge epidural catheter as spinocath comfortably. So, Dr. Priyanka, can you address this?
Ma'am, can you please repeat the question?
So basically, this is a comment from Dr. Rajesh that he has been using at 18 gauge epidural catheter as spinocath comfortably. And I have also, come across this literature, in literature, people using epidural catheter for continuous spinal anesthesia in moribund patients. So what is your take on that? What is the advantage, disadvantage?
It is because of the easy availability of the 18 gauge epidural catheter, but this 25 gauge really prevents this PDPH. If a 25 gauge catheter is available, better use 25 gauge because the rate of PDPH will be definitely reduced when compared to the 18 gauge. Because to introduce this 18 gauge catheter, we'll be requiring more gauze of spinal needle as well. To introduce this 25 gauze, we will be needing 21 gauze spinal needle. So to reduce the PDPH complications, better to go for 25 gauze spinal catheter.
Because there is a play between the 18 gauge catheter, which will make a wider hole in the dura, bigger hole in the dura.
Yes.
So I
And
think
because we'll be using it for post-operatively 72 hours
Exactly,
to reduce
yes.
the PDPH, better
Yes.
go for 25 gauze
there will
catheter.
be there is a possibility of leakage post-operatively also through this. So there is a comment from Dr. Naresh Paliwal that directing the catheter caudally is not recommended as it can lead to cauda equina syndrome. I think that is a valid comment. Okay, Dr. Namrata has asked, we use continuous spinal with 19 gauge 2E needle and catheter as we do not have spinocath access in our institution. So I think this is a common practice in periphery and in many institutes, because this spinocath has cost concerns and it is not easily available. I have also heard about it. So any of the speaker has personal experience regarding this use of 2E needle, though we have already mentioned about the disadvantages, but any of you have your personal experience in using 2E needle for continuous spinal? Dr. Priyanka, have you ever used it?
Yes, we have used Tuhi needle for continuous spinal, but PDPH was a concern because before acquiring this Pajung set, we were trying this study. Then we had to use this Tuhi needle, but patient cooperation was a difficulty because of the wider bore needle, and we have seen PDPH in many of these cases where we have used. So it is definitely not advisable to use this Tuhi needle if you have an access for better gauze spinal catheters.
Yeah. I think in interest of time, we'll move to the next segment, which is site-specific surgery. So we have a very eminent speaker. We are privileged to have Dr. Shiva Shanmugam. He will be speaking on awake clavicular surgery. So regarding Dr. Shiva Shanmugam is currently working as a professor in Department of Anesthesia and Pain Medicine, Mahatma Gandhi Medical College and Research Institute, Puducherry, India. And he has special interest in ultrasound-guided regional anesthesia, acute pain and vascular access. He's currently the program director for fellowship in ultrasound-guided regional anesthesia. And he's the secretary for board of studies in AORA fellowship. And he has 47 publications to his credit and many citations and patents. We welcome you, Shiva sir, to proceed with your talk.
Good evening, everyone. Myself, Dr. Shiva Shanmugam, works as a professor at Mahatma Gandhi Medical College and Research Institute, Puducherry, India. Thanks, Dr. Sandeep sir, for giving me this opportunity to speak on World RA Day. Dear friends, to impact and sustain the benefit of regional anesthesia to our patients, in the future upcoming days, we need to provide more and more rapid acting, highly successful, consistent regional or surgical anesthesia blocks for our patients. Otherwise, the acceptance by the surgeon and the patients are going to be smaller. Towards this end, the surgical anesthesia is clavicle is one of the evolving, still not well established area. So in this presentation, I am going to talk about the nerves involved in the nociception during the clavicular surgery, and then to demonstrate what are all the different approaches are available to block these nerves, and then to which one to choose. I am going to provide you the comparative pharmacodynamics or block dynamics, and then finally to show you one real life scenario, you can see what is the benefit of site specific blocks, and then finally take home message. So to do a awake clavicle surgery, the first and the foremost thing is we need to understand what are all the nerves innervate those surgical area. So these things are classically explained by dermatome, myotome and osteotome. If you look at the clavicle is innervated, the skin over the clavicle is innervated by supraclavicular nerves which are arising from the superficial cervical plexus. Suppose if the incision is false on the acromioclavicular joint, the incision line might extend into the axillary nerve area. So, I cannot give you a strategy for clavicle surgery and AC joint. So, the dermatome in case of a clavicular surgery includes supraclavicular nerve as well as the axillary nerve. Similarly, if you look at the muscles, these are all the muscles associated with clavicular surgery. The first and the foremost is the pectoralis major muscle, which originates from the anterior border of the ventral surface of the clavicle on the medial 2/3. Whereas the deltoid muscle originates from the lateral 1/3 of the ventral surface. The trapezius muscle, which is a bigger muscle, inserted on the posterior border of the ventral surface, which is supplied by the spinal accessory nerve. And then some anatomical literature tells that T3 also innervates the trapezius muscle. And then the fourth muscle is the sternocleidomastoid muscle, which is attached at the medial end of the clavicle, which receives its innervation from spinal accessory nerve. The last muscle is nothing but the subclavius, which originates below or under surface of the clavicle, inserted into the first rib, that receives supply from nerve to subclavius. So essentially, if you look at the myotome, it receives branches from the brachial plexus, that is lateral pectoral, axillary and subclavius nerve, and the cranial nerve, that is a spinal accessory nerve, and some unnamed direct branches from cervical plexus. So coming to the osteotome, the ventral surface is essentially supplied by supraclavicular nerves from cervical plexus. The lateral 1/3 is supplied by the suprascapular nerve from brachial plexus. Whereas the under surface is essentially supplied by subclavius nerve, and then the lateral 1/3 is supplied by the lateral pectoral nerve. Again, if you look at the osteotome, it receives branches from both the cervical plexus as well as the brachial plexus, supraclavicular nerve from cervical plexus, suprascapular, subclavius and lateral from brachial plexus. Now, to consolidate everything, to put together, the surgical innervation of the clavicle arises from cervical plexus, brachial plexus and then cranial nerves. The cervical plexus provides supraclavicular nerves and some direct branches from C2 and C3, whereas brachial plexus offers nerve to subclavius, suprascapular nerve, lateral pectoral nerve, axillary nerve, and then the cranial nerves provide spinal accessory nerve. Now you can understand why the surgical anesthesia block for clavicle is so complex, because it doesn't receive its innervation from any single plexus, it takes from multiple sources. So that is the key to understand. So now coming to understand the strategy, we have to know from where these nerves are coming from. If you look at the cervical plexus, either you can deposit the local anesthetic directly under the sternocleidomastoid and block all the branches of the cervical plexus, that is a non-selective block, or with the advent of ultrasound, you can selectively scan the supraclavicular nerves and then you can selectively inject them. Similarly, if you look at the brachial plexus, the branches originates from different levels. If you look at a suprascapular nerve and subclavius, it comes out of the upper trunk, whereas the lateral pectoral C6. If you block the upper trunk, which is a junction point of C5 and C6, instead of blocking all these individual nerves, we can block with only one injection, that is at the upper trunk. That is how upper trunk plays a crucial role in the RA strategy of clavicle. So now look at, with all this background in mind, we can categorize the RA strategy for clavicle into two groups. One is a peripheral nerve block, another one is a facial plane blocks. The peripheral nerve blocks can be further divided into non-selective and then selective. So now let us look at what are all the techniques available. The non-selective peripheral nerve block includes a superficial cervical plexus plus our conventional interscalene brachial plexus block, because here we are not targeting any specific component. Whereas in the selective peripheral nerve block, there are two options available. One is supraclavicular nerve block plus you can selectively inject into the C5 nerve root. The second technique is a scud block, which is nothing but supraclavicular nerve block plus upper trunk block. The third one is the facial plane block, which is the supraclavicular nerve plus clavipectoral facial plane blocks. So this is how I can able to categorize the blocks which have been described as on date for surgical anesthesia for clavicle. Now let us look at how these are all traditionally been done. If you take the non-selective peripheral nerve block, During the supraclavicular plexus block, you can inject the local anesthetic between the sternocleidomastoid muscle and the anterior scalene. You can inject 10 ml. That will block all the branches of superficial cervical plexus. Whereas in the interscalene groove, if you inject about 15 ml of local anesthetic, it can block the C5, C6, C7 and then C8. So when you inject such a high volume of local anesthetic, you can see the local engulfs the entire brachial plexus elements, that includes upper trunk, middle trunk, to some extent the C8 nerve root as well. So now if you do the selective on the other side, you can inject the supraclavicular nerves at the lateral end of the sternocleidomastoid muscle between the investing layer, that is a green line, and then the prevertebral layer, which is a blue line. Even in this image, you can appreciate this is a lateral end of the sternocleidomastoid. The white line that attaches to the sternocleidomastoid is an investing layer, whereas this is an anterior scalene, middle scalene, and the layer that goes on top is a prevertebral layer. Between these two things, you can appreciate a group of bunch of nerves. This is a supraclavicular nerves, and this is the phrenic nerve on the anterior surface of anterior scalene muscle. If I scan them, you can understand as we go down, the supraclavicular nerves goes to the skin, whereas the phrenic nerve moves more medially. So this is how we will identify the supraclavicular nerve group over the between the two investing on prevertebral layers of cervical fascia. So now when you inject, you can do a selective injections that is close to the supraclavicular nerves. You can see how close is the phrenic nerve even when you do a selective injection. So this group is the supraclavicular nerve, this is the investing layer, and this is the prevertebral layer. We inject about 1 to 2 ml of local anesthetic around the supraclavicular nerve. This is how we will do the selective supraclavicular nerve injections. Coming to the upper trunk, you can trace them into the interscalene groove, and you can use a finer needle. This is a 25 gauge Quincke needle, and deposit small liquids of local anesthetic inside the upper trunk. So this is an upper trunk, this is C5 and C6, whereas this is the C7 middle trunk. Here we are injecting about 2 to 3 ml of local anesthetic selectively into the upper trunk. This is a post injections. Now you can see the 3 ml of local anesthetic is well soaked the upper trunk, but it doesn't spread anywhere else. So now you can see this is the middle trunk, that is the upper trunk. This is how the injections between selective and non-selective differs. So now you have injected, what to expect? Whenever you do a selective injection, what are all the block dynamics? This is a pre-scud block. You can see the shoulder movement is completely intact, and the patient can flex his elbow, and then the wrist and the finger movements are completely intact. See, after the scud block, if you look at, you can see the sensory changes are only on top of the clavicle. The patient is not able to abduct the shoulder, and then the elbow is paralyzed, whereas his wrist and the finger movements are completely intact. Only the supination the patient finds difficulty because it comes from the few of the fascicles of the radial nerve. Otherwise, wrist extensions, thumb extensions, everything will be very easy. So now the patient himself can keep the hand in supinations. He can do an opponents very effectively, that is a median nerve, ulnar nerve, and then the radial nerves are completely intact. This is the benefit of selective nerve injections. Then coming to the third one is the facial plane blocks, where we know that the clavipectoral fascia engulfs the clavicle and then provide us a pouch to inject the local anesthetic between the clavipectoral fascia and the periosteum of the bone. When you inject 10 ml of local anesthetic on either side of the fracture end of the clavicle, they have described that it can provide a surgical anesthesia. So now which one to choose? We have three options. One is a non-selective peripheral nerve block, another one is a selective, and the third one is the facial plane block. So as of now, there is no clear-cut randomized control trial that tell us which one to choose. In this project, we have completed a RCT in our institute where we randomized 3 clavicle fractures into 3 groups. One is a non-selective, another one is a selective that we did a scud block, and then the facial plane block on the third group. If you look at the success rate in the interscalene groove, when we inject 25 ml, that is 10 ml into the superficial cervical plexus plane, and then 15 ml into the interscalene groove, the success rate is 100%. If you look at the phrenic nerve involvement is about 50%, and the hand grip strength is decreased by 60%, the pulmonary function is dropped by 23%. Whereas when you do a scud block, the success rate is about 92%, whereas the phrenic nerve involvement, to surprisingly, it is about 30%. The finger grip strength is decreased by 60% and pulmonary function is dropped by 22%. Essentially, these two things are in equal. There is no big difference between non-selective block and a selective block. Whereas when you go to the facial plane blocks, the clavipectoral fascia plane blocks preserves the diaphragm better. The diaphragmatic involvement is only 30%. The finger grip strength is decreased by only 10% and the pulmonary function dropped by 15%. This profile is very good, but if you look at the success rate is only 40%. In this RCT, we discontinued the group of clavipectoral fascia plane block because more than 50% of the patients required some amount of supplementation. So this is the disadvantage of clavipectoral fascia plane block. So now to demonstrate one real life scenario, in this patient he has got a multiple rib fractures on the right side with a clavicle fracture. He has been posted for open reduction and internal fixation. If you look at his heart rate is about 130, the saturation was 90, he couldn't able to even sit. If you look at closely, his respiratory pattern is only the left chest is moving, the right chest is completely still, he couldn't able to lie down. So for him what we did was, we did first the thoracic epidural, relieved his rib cage pain, and then we did the selective, the scud block, supraclavicular and upper trunk block. This is 1 hour after the surgery. If you look at his heart rate is dropped to 114, the room air saturation is almost 100%. When we ask him to take a deep breath, you just see the how he breathes. His chest expansion is really good. Without any hesitations, he could able to take a full vital capacity breath. So, and he is completely pain free. And we assessed his pulmonary function test also at the bedside. He could able to blow out and do an effective vital capacity maneuver. He has reached almost 80% of his predicted value. Similarly, when we assessed his hand grip strength, you can look at he can able to squeeze very well because the median radial ulnar nerve is completely spared. His hand grip strength is about 22 kg. So that means the site specific selective blocks, without affecting a pulmonary function, it can provide a effective regional anesthesia as well as analgesia. So to summarize, the clavicle fractures can be very well fixed under peripheral nerve block. The strategies can be grouped into selective, non-selective and facial plane blocks. The selective blocks provide an optimal risk versus benefit, especially in high risk surgical patients. The clavipectoral fascia plane blocks provides most size specific, least pulmonary intervening block, but unfortunately its success rate is very less, it is about 40%. It works well in only middle third fracture, uncommunicated fracture where the manipulations are extremely less. That is where it works. In other settings it fails. So that is what with me as of now.
Thank you very much, Shiva sir, for that lucid talk. And now I would like to invite Dr. Divesh Arora for his talk on awake humerus surgery, proximal humerus surgery in a COPD patient. Dr. Divesh, as we all know, is a very dynamic person. He is a director and head at Asian Institute of Faridabad, and he is a DNB teacher and examiner and mentor and for regional anesthesia fellowship for IORA. He is a NABH assessor. He has 16 international and national publications and 11 book chapters. He is a past president of Haryana ISA state branch, and he's a faculty for various AORA and other regional anesthesia workshop. He's a very, very familiar face to all in regional anesthesia and focus. And I welcome Dr. Divesh for his talk.
Good evening, ladies and gentlemen. At the outset, I'd like to thank Dr. Sandeep Diwan and Dr. Anju for this opportunity, and I wish everyone a happy Regional Anesthesia Day. Is my screen visible to everyone, Dr. Anju?
Yes, it is very well visible.
Okay. So in next 15 minutes, I shall be covering the awake regional anesthesia strategy for proximal humerus surgery in a COPD patient. I bring greetings from Asian Institute of Medical Sciences, which is a 425-bedded hospital situated in Faridabad in the heart of Delhi NCR. And I've been working in this place for approximately 14 years in various capacities, and I currently head the department there. So these are my set of disclosures. Conflict of interests are nil, and I'm a great RA and POCUS enthusiast. In my presentations, you'll find a couple of QR codes. If you scan them, they'll directly take you to landmark articles. And my references are from PubMed, and a couple of images are from Google. So this is how I planned my lecture. I'll take you through the common scenarios for proximal humerus surgeries. We'll understand in detail the innovation of proximal humerus, and we'll try to devise a RA strategy for humerus surgeries in non-COPD as well as COPD patients, and final conclusion. So these are set of surgeries we commonly encounter in our day-to-day life for proximal humerus, generally open surgeries, fractures, and the treatment of choice is plating, at times intramedullary nails, and in elderly age group, arthroplasties are also indicated. So how do we devise a strategy for awake proximal humerus surgery? First and foremost, we have to take into consideration the type of surgery and the approximate duration, which we need to discuss with our surgeon, and the planned incision and the position of the patient during the surgery. And definitely, in order to plan any RA strategy, we need to know the dermatomes, myotomes, and osteotomes. And do not forget that we should be thorough and knowledgeable about our own skill as to what all blocks we can perform. So let's begin with the cutaneous innervation. This has been already dealt by Dr. Shiva Shanmugam. It's going to be a repetition. So the cape of the neck is supplied by supraclavicular nerves, which are actually the branches of cervical plexus. And the shoulder itself, the humerus area, is supplied by the axillary nerve. And on the medial side, we have contribution from suprascapular, and we all know that axillary and suprascapular are branches of brachial plexus. So in the nutshell, if you actually look at the cutaneous innervation, it's by both the brachial plexus as well as the cervical plexus through supraclavicular nerves. So what about the myotomes? It's the pectoral muscles, which are supplied by medial and lateral pectoral nerve. The deltoid itself is supplied by axillary nerve. The subscapular is by subscapular nerve. The supraspinatus and the infraspinatus by the suprascapular nerve, and the teres minor by axillary nerve. In the nutshell, all by branches of brachial plexus. So what about the innervation to the bone? In the proximal area, it's by axillary nerve on the anterior side and the suprascapular nerve on the posterior side. So proximal humerus would definitely involve some disruption of the capsule. So we need to know the capsular innervation, and it's a very good study published in 2019, and majority of the publications quote this study. So we divide the shoulder joint in 4 quadrants. The posterior superior quadrant is supplied with the suprascapular nerve, which is a branch of superior trunk. The inferior quadrants are supplied on the posterior side by axillary nerve, and the anterior side by axillary as well as lateral pectoral nerve. And the anterior superior quadrant is supplied with the subscapular as well as the lateral pectoral nerve. So this is one of the recommended articles which I would suggest you go through, and where they have defined the nociceptors as well as the mechanoceptors. So they state that the nociceptors are situated in the anterior capsule more in number, whereas the mechanoreceptors and the proprioceptors are situated in the posterior capsule. So this could be taken into account when we are planning the analgesia strategy. So 3 important nerves are particularly important for anesthesia analgesia are suprascapular, lateral pectoral, and the axillary nerve. So we have studied in detail the innervation which is required for proximal humerus surgeries. It's from 4 principal nerves: the suprascapular nerve, which is a branch of superior trunk; axillary nerve, which is a branch of posterior cord; the subscapular nerve, again a branch of posterior cord; and the lateral pectoral nerve, which is a branch of lateral cord. If you actually look at the nerve root levels, all of them principally carry the nociception and through C5, C6 towards the neuraxis, except for a small contribution from C7 from the lateral pectoral. So ultimately, if we can block C5, C6, we should be able to achieve anesthesia analgesia for shoulder surgeries. That is the take-home message which I wish to give. So the gold standard, my dear friends, for awake proximal humerus surgery, is interscalene brachial plexus block. But whosoever has performed this block would know that phrenic nerve palsy or paralysis is a consequence, which Dr. Shiva has already elucidated. So how does phrenic nerve get involved? So let's have a look at the anatomical dissection. The phrenic nerve runs on the surface of the anterior scalene from lateral to medial surface. So close to C5, C6, it's very close. As we descend down by 1 centimeter, it moves away by 3 millimeters. So if we are performing the interscalene, the chances of phrenic nerve are much more than if we are performing at the level of superior trunk. And if you're performing at the level of spa arrangement, the chances would be much less. So we have to devise a strategy in such a way that the consequences are minimalistic in such patients. So how do we actually assess phrenic nerve palsy? It's very easy. We can use a curvilinear transducer and assess for the subcostal excursions of the diaphragm pre-block as well as post-block and evaluate the reduction. And we can evaluate the thickness fraction using a linear transducer in the zone of apposition and look for pre as well as post changes. Another method is to use the pulmonary bedside pulmonary function test, which can help us in defining the reduction in the phrenic nerve contribution. So why is there so much of cry for hemidiaphragmatic paralysis? So it's categorized as if there is a 25% decrease, then it's normal. If it's 25% to 75% decrease, it's known as partial. And greater than 75% decrease from the pre-op levels, it's defined as a complete paralysis. So if an individual develops a paralysis, so what does it amount to actually? The SpO2 is said to decrease by 7%, the PaO2 by 7 millimeters of mercury, and the PCO2 increases by 3 millimeters. Whereas the pulmonary function test, FEV1 decreases approximately by 16 to 40%, FVC by 13 to 40%, and the peak expiratory flow rate by 15 to 40%. So in the nutshell, there is a decrease by 15 to 40% in the pulmonary function test with a slight decrease in the SpO2 and increase in the PCO2. A normal individual can tolerate all these decreases very well, whereas a patient who has got a severe or a moderate COPD who's symptomatic might not be able to tolerate all these changes. So we know that interscalene brachial plexus block is the gold standard. So in such subset of patients, how can I reduce the incidence of phrenic nerve palsy with interscalene block? First and foremost is use ultrasound. Keep a close attention to the volume and the concentration. These are certain references, landmark articles, where they have stated as early as 2011 that 5 ml is the MEV 90. And for catheters, it's 7 ml. It's a very recent study published in Journal of Clinical Anesthesia that MEV 90 for 0.5% ropivacaine for anesthesia is just 8.64 ml. So in the nutshell, we need not use the traditional 20 to 30 ml of the drug. We need to pay attention to 0.5% ropivacaine. That is good enough. And we can use anywhere between 6 to 10 ml of the drug for anesthesia. So this is a quite old article where I tried to modify the approach to interscaling. So instead of depositing close to C5, C6, can we deposit alone at C7 and achieve anesthesia? The answer is yes. With 3.6 ml, they were able to show MEV 95. So where do we actually deposit the drug? So Dr. Shiva has already shown a couple of videos on interscalene brachial plexus. There are two approaches. One is the periplexus approach. That means you deposit the drug between the brachial plexus sheath and the epimysium of the middle scalene. That is known as periplexus or extrafacial, as shown on the left side of the video. Another is you do an aggressive needling, as this is the case, where we are trying to go between C5 and C6, and this is known as intraplexus or intrafacial. So there are a couple of studies as well as meta-analysis which have shown that if you actually take the intraplexus or the intrafacial approach, then because of the retrograde spread of the drug towards C3, C4, C5, the phrenic nerve palsy and paresis is much higher in comparison to periplexus extrafacial. So if you wish to reduce the incidence, then periplexus extrafacial, pay attention to 6 to 10 ml of the volume, and 0.5% ropivacaine is good for anesthesia. So are there any other alternatives that if I do not wish to use interscalene, can I use other brachial plexus block approaches for providing regional anesthesia for awake proximal humerus surgeries? The answer is big yes. So this is another recap that the principal targets are C5, C6. It's through these segments that the nociceptive stimulus is traveling to the brain through near axis. So if we are able to block C5, C6 at the level of superior trunk, it would be superior trunk block. We can block at the level of trunks and divisions, supraclavicular. We can block them at the level of cords in the medial infraclavicular fossa at the costoclavicular level, and at the lateral infraclavicular fossa at using the infraclavicular approach. But in that case, suprascapular would have to be blocked extra. So let's understand one by one what these strategies could be. Superior trunk block was defined in 2014 by Burkett and colleagues, where they said C5 and C6, where they actually come close and are surrounded by a sheath, is the target, so that we are much away from the phrenic nerve and can reduce. So this was the proximal approach to superior trunk block described in 2015. Subsequently, as we can see, the results are quite fascinating. It has been used for shoulder surgeries and for clavicle surgeries, as Dr. Shiva has mentioned, and the phrenic nerve palsy, even with 15 ml of the drug, drops to 5.3% or 4.8%.
Block provides non-inferior analgesia compared Acpatron block.
So can somebody mute Dr. Ofelia? Yeah, thank you. So in 2016, there has been a distal superior trunk block approach, which has been described by Aguirre and colleagues, where they stated that instead of blocking at the fusion, you block at their split at the level of SPA, taking care that you do not miss the suprascapular nerve. As you can see for yourself, we are much away from the phrenic nerve, and the distal approach was cited to have a hemidiaphragmatic incidence of 6.3%. So the next question comes, can supraclavicular block be used for proximal humerus surgeries? The answer is big yes, but the only caveat is that we have to take care that we also block the suprascapular nerve. At times, too much of tilting towards the thorax will make the suprascapular nerve lie somewhere here, and we might miss it as a novice. So the take home is that take care that you also inject around suprascapular nerve, and the MEV 90 is 15 mL, and the diaphragmatic paresis drops to just 9%. What about costoclavicular brachial plexus block, which is described by Manoj Karmakar and colleagues in 2015 at the level of medial infraclavicular fossa? The cords are lying in a cluster in the triangular compartment, as you can see for yourself. So it's an excellent anatomical study done by Koila Moody and colleagues, where they actually showed that the suprascapular nerve was stained in all the anatomical cadavers because of the retrograde diffusion of the drug superiorly. So this gives us a hope that costoclavicular, which is nowadays some of the authors call it as the new spinal of the arm, can be successfully used for proximal humerus surgery. What is the median effective volume? It's around 18.9 mL, and the various studies have been done, and one by Shiva, Shanmugam and colleagues, where they showed actually it was 5% hemidiaphragmatic paresis, but LST and colleagues, they showed 0% with costoclavicular block. It all depends on the volume as well as the speed of injection. So can we use infraclavicular brachial plexus block? The answer is big yes, except for the fact you will have to add the suprascapular block, because suprascapular is a branch of superior trunk. It escapes from the brachial plexus quite early. So this was the ISO block, infraclavicular plus subomohyoid, that is the anterior approach to the suprascapular nerve, described by Ahmed Tah, and there have been RCTs where the incidence of phrenic nerve is only 5.6%. So if we are planning to give anterior suprascapular nerve just underneath the omohyoid, the technique has to be you deposit where it has just dissociated from the SPA arrangement, as well as do not use more than 4.2 mL of the drug. That is the effective volume, as well as chances of phrenic nerve is 0%. So my dear friends, we have understood that what all brachial plexus strategies we have to use. Do we need a separate supraclavicular nerve block? The answer is big yes. Supraclavicular nerves are branches of the cervical plexus. If you're using a high volume interscalene brachial plexus, as we used to do previously without ultrasound guidance, then we need not need a supraclavicular nerve block, because of the retrograde cephaloid diffusion of the drug. It will block the cervical nerve roots. But because we are in the era of procedure specific, site specific, using very low volumes of the drug, so this has to be blocked separately. And Dr. Shiva has explained it very nicely that we have to deposit the drug in between the investing layer of the deep cervical fascia and the prevertebral layer of the deep cervical fascia, taking care that we do not go close to the phrenic nerve. So at times for proximal humerus, when the surgeons are using the deltopectoral curved incision approach, they might encroach onto the area of the medial arm, which is supplied by costobrachial and the medial brachial cutaneous nerve. We very well know that the intercostobrachial nerve is the lateral cutaneous branch of the T2, which will never be blocked with any brachial plexus approach. And the medial cutaneous nerve of the arm is the branch of the medial cord, which will not be technically blocked with the interscalene at times. So you need to block these branches very separately in the case where there is a curved incision. It's very easy. You can do a subcutaneous infiltration or ask the surgeon to infiltrate it. And the technique which I generally use is from Magazinis, described in 2018. We try to visualize the fusion of the conjoint tendon with the brachial fascia, as we would do for axillary brachial plexus block, and move the probe a little caudal and deposit 2 to 3 ml of the drug, and this would take care of these. Now coming on to, we have discussed various approaches. So how do we go about the decision pathway for doing a awake proximal humerus surgery in a COPD patient? First and foremost is history, physical examination, and if there is an active wheeze and all, try to convince the surgeon and get the respiratory medicine people involved so as to take care of the active disease. Otherwise, if the patient is not having a well-controlled disease, then in mild to mild, we just go for interscaling, as I said, 6 to 10 ml and periplexus approach. Moderate goal to criteria, you can use any of these: superior trunk block, costoclavicular, and the ISO block. And in severe and very severe, we have to be very cautious. So infraclavicular brachial plexus and the posterior approach to suprascapular nerve. And if we are very good at needling and identification of the suprascapular nerve in the subomoid plane, anterior suprascapular nerve block can also be thought with 4 ml of the drug. And do not forget to combine it with a supraclavicular nerve block, which are the branches of the cervical plexus. And if the incision is too medial, then please combine intercostobrachial nerve also. So how do we actually do it in our day-to-day life, the intraoperative conduct? So we generally place a L-shaped screen, generally done in 30 degrees head up. Patient warmer is placed. We give a Dexmed sedation, light music, and pillow under the knees to make the patient comfortable, supplemental oxygen if required, and ETCO2 monitoring and careful BP monitoring. So generally in spontaneous breathing patients, we have to do a jugaad that we have to attach the sampling line under the face mask, and with nasal prongs, if we wish to give low oxygen for COPD patients, it's not possible. So these are devices by intersurgical, the Sentry ETCO2 cannula, where they have an extra sampling line which is attached to the face mask or as well as the nasal prongs, and easily available by intersurgical, a little expensive, but they give you a good ETCO2 trace, as you can see for yourself, as good as the conventional under GA. So in case you have done your best and you do get some dyspnea from the patient, or patient is feeling little uncomfortable, so propped up position is already there in beach chair, give them supplemental oxygen and consider non-invasive ventilation in the form of HFNC or CPAP if it's possible. And worst case scenario, ventilator support could be done. If the surgery has already started, a saline wash cannot be considered, but if the surgery is yet to start, you can just again scan the area and give 10 ml of saline, 10 to 15 ml of the saline, and it will help in diluting the phrenic nerve blockade, and it gives some immediate relief. There are a couple of references in the literature, although I have no practical experience with that. So this brings me to almost to an end. I always call it as a food court approach, where you know your strengths, you know the blocks available to us, and choose the block very wisely. My dear friends, for anesthesia analgesia, we have these 5 options: low volume interscalene, superior trunk block, supraclavicular brachial plexus, costoclavicular, and the ISF block. Do not forget to do a supraclavicular nerve block. And in case it's purely an analgesia block, apart from this, there are so many blocks available to us: shoulder block, the posterior and the anterior approach, subscapularis plane block, described by Rakesh Sondekopam and colleagues, 2016. It's nothing else but an anterior approach to the axillary nerve and the subscapularis nerve. The Peng shoulder, further described. The high thoracic ESP at the T2 can be used. Dr. Sandeep Diwan has a couple of publications on that. The Shack block has been described, the shoulder anterior capsule block, by our pain physicians, 2021, and we have used it very successfully for chronic pain patients. And the periarticular vasoconstriction infiltration, described by Vincent Rocks and colleague, and it has been described for spine, knee, hips, and shoulders. And very recently, the infraspinatus teres minor block and the anterior glenoid block. So not wasting time, the understanding the anatomy is the key, the innervation of the particular region we need to know your patient, always discuss with the surgeon the position of the patient, the incision, the anticipated duration, and do not forget that you have to know your skill and choose your RA technique wisely. And thank you very much for patient listening through this platform. I take this opportunity to invite you for AORA 2025 annual conference at Amritsar on 18 to 21st September. Thank you very much for this opportunity.
Thank you, Dr. Divesh, for your excellent talk. I think there would be a lot of take-home messages for the listeners. And you also described multiple new updates on the proximal humerus surgery, multiple blocks which have been recently described. So thank you very much for your excellent talk, and also thank you for mentioning AORA 2025. All the audience globally, they are welcome to AORA 2025. Now, without wasting any further time, I would like to invite Dr. Sandeep Diwan to deliver his talk on proximal femur surgery in a frail elderly patient. So Dr. Sandeep Diwan is a senior anesthesiologist who is working currently at Sancheti Hospital, Pune. He is the head research department of anesthesia, Sancheti Hospital. He is the editor of International Journal of Regional Anesthesia. He is the AORA chairman and chairman of the Cadaveric Board of Studies at AORA. I welcome you, Sandeep sir, to deliver this talk.
So you can start.
So good evening, everybody. On behalf of the World Regional Anesthesia Day, jointly hosted by the ESRA, the Aura, as well as PRAC, we welcome all the delegates. And the theme is Awake Regional Anesthesia, and I would be talking on the proximal femoral fractures in frail geriatric patients. I'm a consulting anesthesiologist and head research in Sancheti Hospital, Pune, also chairman of the Cadaveric Research and Academic Board of Studies, Aura, and as well as the editor of IGRA, which is affiliated to Aura as well. I have been working here for last 10 years in this hospital, which has almost like 300 beds. There's a big tower which we have just come up with, which is the advanced orthopedic care, and we mainly work in orthopedic setup. So proximal femoral nails are common in intertrop fractures, and they have to be operated within 24 hours. They have multi-comorbids and may or may not have frailty. More than 80 years of age, there is a high incidence of perioperative mortality, and the role of anesthesia, or the type of anesthesia, is still controversial. But at the end of 30 days, the mortality rate remains the same, irrespective whether we implement a regional or a general anesthesia. But if you look at the choice of the relatives and surgeons and even the anesthetists, most of the times it's regional anesthesia, so that the patients are awake at the end of surgery, where the relatives and the surgeons can interact with the patient, and also that the patient can come out of his nil by mouth status. Regional anesthesia can be of various types, like it can be a single shot spinal, a continuous epidural, or a combined spinal epidural, or a lumbosacral plexus block. Now, we know that when we do a spinal, it could be a bilateral sympatherectomy. With epidural, it's segmental, while with lumbosacral, it's a unilateral sympatherectomy. So the hypotension which is produced is more with the spinal, obviously less with the epidural, and the least with the lumbosacral plexus blocks. Secondary outcomes in 11,000 patients in this particular ASAP2, they have concluded that with the lowest mean blood pressures of 50, the fifth day mortality was around 1.5% to 1.8, while the 30th day mortality was somewhere around 6.2 to 6.3%. And also, when you inject around 1.5 ml of local anesthetic, there would be a fall in the blood pressure by 20, while with 2.5, it would be a fall in the blood pressure by 40 millimeters of mercury. Now, why would the fall in the blood pressures would be important? Because it affects the clinical outcome. Now, again, database of more than 33,000 non-cardiac surgeries, a mean arterial pressure drop of 55 millimeters of mercury. It affected the kidney and the myocardial in the form of acute kidney injuries, cardiac complications, and myocardial injuries. And it all was dependent on the time the patient was exposed to hypotensive state from the 5th minute to 20th minutes. So we have an instituted protocol where departmental protocol where most of the times, like 75% of the times in ASIC grade 3 with ejection fraction of more than 45% and no regional wall motion abnormalities, it's usually a unilateral spinal. While in less than 20% in the same ASIC grade 3 with a ejection fraction of less than 45% with regional wall motion abnormalities and patients on inotropes, it's a segmental epidural. And in fact, if the ejection fraction is less than 35% with the patient having regional wall motion abnormalities and patients on inotrope, it would be more of a lumbosacral plexus block. If you look at this particular comparative hemodynamic status, you will find that when you introduce a spinal anesthetic, the fall in the pressures is significant as against the fall in the pressure and the heart rate, which is insignificant in the epidural anesthesia. One of the important things is, apart from the technique, is the monitoring. Now, most of the times we monitor with this particular monitor where there's a continuous stroke volume and cardiac output monitoring techniques. Now, in the awake patients, we don't do the stroke volume variation. So this is what is implemented in patients who have been undergoing segmental epidural and the lumbosacral block. So when you do an epidural, we usually implement at the level of L2, L3 with the catheter somewhere at the level of L1 and L2 or maybe T12 and L1. And we use 2% lignocaine and 0.5% bupivacaine to achieve segmental analgesia anywhere from T12 to around L3, L4. And it would be sufficient to anesthetize the hips in the supine or in the lateral position. Now, this is a surgical procedure where the patient is around 95 years old and with several comorbids that was brought with the inotropic agents, a segmental epidural with just 5 to 6 ml of local anesthetic in the sitting position and another 2 ml in the supine position was more than enough for the surgical procedure to be performed. Now, most of these patients are monitored either with a radial artery cannulation or with the Edwards cardiac output, and a small amount of sevoflurane is always inhaled by the patient for the patient to be comfortable in the intraoperative period. Now, the epidural would be contraindicated in patients with spinal canal metastasis, spinal instrumentation, severe scoliosis, multiple sclerosis, and myelomas. So one of the alternative techniques is to go paraspinal or paravertebral, where to identify the lumbar plexus in the psoas major. The most important part in this particular technique is to identify the transverse process. So when you have the osseous contact with the transverse process, this is the most important part. And just beyond this, around 1.5 to 1.8 would be the lumbar plexus. When the needle contracts the lumbar plexus, the cordyceps contractions would be the end point, and this is at 0.4 milliamperes. Now, again, when you do these blocks, we do it in the lateral position, and the surgical site is non-dependent. And the cordyceps contractions are of the cordyceps contractions are of importance. You can see the extension of the leg, as well as you can see the patellar dance here as well. And we inject around 0.2 ml per kg body weight for the lumbar plexus. It's always supplemented by the sacral plexus as well. So when you're injecting local anesthetic into the lumbar plexus, it's usually this bluish oval which occupies the psoas compartment or the lumbar plexus and blocks the lateral femoral cutaneous, the femoral, and the obturator nerves. So perioperatively, this is the local anesthetic that we use for lumbar plexus block. It's 0.2 ml per kg body weight, and we do it with neurostimulation guided block. And if required, we use ultrasound. No, most of the times we do not need an ultrasound, but if you want to identify the needle to nerve contact, then you can use the ultrasound as well. It's also important to implement the sacral plexus block. This is the plantar flexion at 0.1 ml per kg, 0.5% bupivacaine and 1% xylocaine that we use in both these patients. Now, if you see that both these patients are being monitored with the radial artery cannulation, and you would see the pressures are on a very higher side in this particular patient, and is being monitored with the Edward Vigilio system. We monitor the cardiac output and the stroke volume in both these cases. And we have recently also published this comparative study between the lumbar plexus, the epidural, and the spinal. This is just to exclude that it's not an epidural diffusion after a lumbar plexus block. You can see the patient can flex the unoperated side. So the contraindications would be for the lumbar plexus, which is technically more demanding, is the patients who are on anticoagulants, or patients who have got coagulopathies, have severe hepatic disorder, renal disorders, or scoliosis. These are the conditions where the lumbar plexus might be contraindicated. And more importantly is the postoperative care in these patients. With a hemoglobin of less than 8, you need to transfuse red blood cells. And if the oxygen saturation is less than 90, you need to supplement with humidified oxygen. This is to decrease the incidence of cerebral vascular accident and the myocardial infarction. We also need to take care of the renal of the kidneys by having the GFR at more than 60 ml per minute, and the electrolytes where sodium should not be less than 130. One of the key performance indicators is early remobilization, re-enablement, and rehabilitation. And this is one which can definitely occur when you use the regional blocks. Now, this is a patient who claims to be of age 103, who had operated with proximal femoral nail for fracture intertroch under lumbosacral plexus block, and this is the post-operative day 1 ambulation the next day morning. So he was operated at 8 in the morning, and the next day 8 he was made to mobilize. So that's the importance of mobilizing these patients in the immediate post-operative period. Now, is lumbar plexus block a motor sparing? Now, this is important to understand that the lumbar plexus blocks, though they have been said to anesthetize the femoral, the lateral femoral cutaneous, and the obturator, you can see that this patient, where a periprosthetic fracture was operated upon. Now, this patient could lift her leg on her own, and we could see that is the reason why there could be a possibility of the patients getting mobilized in the early postoperative period. So to conclude, the need of the R is a protocol-based fast-track admissions and immediate operations. The earliest that we were operated from casualty to the operation theater and to the ICU was 4 hours, and the maximum was less than 24 hours. We have been told by our surgeons that the incidence of 30th day mortality has gone down from almost 18 to 20% to 6%, and that's a significant reduction. There's need of multidisciplinary care. It's not only the anesthesiologists, but it's the surgeons, the physicians, the intensivists, the geriatric orthogeriatricians, as well as the physiotherapists, all coming into action to take care of the patients. The earliest time to surgery is less than 48 hours, and there is a need of geriatric anesthesiologists as well, who would take care more of these geriatric patients. Usually we get them when they are beyond their 80s. And we also require high quality interdisciplinary departments. So to conclude, in fractures of the intertroch, ACE grade 3 and grade 4, it's our opinion though when we say our opinion, the evidence decreases, but then a selective spinal, we still find the patients requiring noradrenaline infusions in the perioperative period. And we found that the epidural and lumbosacral plexus blocks are hemodynamically, the patients are more stable, not requiring noradrenaline at the end of the surgical procedures. They would be ambulatory in the immediate postoperative period, and they would be discharged home earlier than the patients who had undergone spinal. So we still feel that these two techniques would be very useful in patients who are at very high risk, as we have mentioned earlier. So thank you very much for the kind attention. We move on to the next talk.
Thank you, Sandeep sir. There could not have been better speaker for this topic, as we call Dr. Sandeep sir master of lumbosacral plexus block. So I'm sure the delegates would have enjoyed his talk and would have benefited from it. Last but not the least, we have Dr. Amjad Maniar, who will be speaking on continuous lumbar spinal anesthesia after the wonderful talk on continuous thoracic spinal anesthesia by Dr. Priyanka. So I welcome Dr. Amjad Maniar to proceed with his talk on continuous lumbar anesthesia.
Greetings. I extend my sincere gratitude to Dr. Sandeep Diwan and Dr. Anju Gupta for organizing this webinar in celebration of the Second World Regional Anesthesia Day. It is truly inspiring to see how regional anesthesia has evolved over the years, reaching such prominence that medical societies worldwide have come together to dedicate a day to honor its significance in clinical practice. Today, I am excited to share insights on a technique I am particularly passionate about, that is continuous spinal anesthesia. I have no disclosures to make in regard to today's talk. By definition, continuous spinal anesthesia is a technique of intentionally producing and maintaining spinal anesthesia with small doses of local anesthetic, which are injected intermittently into the subarachnoid space via an indwelling catheter. We often hear of anecdotes where a catheter is pushed into the intrathecal space after an accidental dural puncture while placing an epidural catheter. This is often done to prevent PDPH, and the entire dose of local anesthetic is given. This sort of practice is not considered to be in line with the continuous spinal anesthesia. Why use continuous spinal anesthesia? Well, the primary reason is that it is a very stable technique hemodynamically, and there are multiple reports and literature on its use in patients with aortic stenosis, carotid stenosis, high-risk laparotomies, and especially in the elderly and compromised coming for lower limb surgery. As we know, with spinal anesthetic, it provides high quality of surgical anesthesia with small doses of the drugs. As with the catheter, there are no limits on how long the anesthesia can be prolonged to, and it can be used selectively for postoperative analgesia. Literature is considerably sparse on the application of continuous spinal anesthesia in practice. Most of the articles that you would encounter are case reports on its use in the severely ill patients, especially those with cardiac and pulmonary illness. So these are two papers that show the application of the continuous spinal anesthetic in hip repair and femoral fractures in patients who had aortic stenosis. Another interesting paper from about 25 years ago looked at continuous spinal anesthesia in two patients for hip surgery with severe aortic stenosis. These were the elderly patients, 84-year-old male and a female, both with CCF and very tight aortic stenosis and reduced ejection fraction. These patients had continuous spinal catheters placed in them preoperatively and had a multitude of monitoring modalities incorporated. Now, if you look carefully at the blood pressure, which is something very basic that we are interested in, you can see that after induction of the continuous spinal anesthesia in a bad heart, the blood pressure has remained fairly constant throughout, thereby showing that this sort of technique may be successfully applied in these risk patients. Surprisingly, the continuous spinal anesthesia technique is over 100 years old. There have been many modalities used to perform the continuous spinal anesthesia, including leaving the needle into the intrathecal space. Edward Toohey in the 1940s used 15-gauge ureteric catheters placed into the CSF space to perform continuous spinal anesthesia. But modern day continuous spinal anesthesia dates back to the early 1990s, when there was this report on continuous spinal anesthesia used with something called a microcatheter. Now, a microcatheter was a 32-gauge polyamide catheter with a 35-gauge stylet inside, and this was inserted through a 22 to 26-gauge spinal needle. Now, back then, they tried this out on 24 patients and they encountered a certain set of problems which are even present today. It was difficult to thread in the catheter sometimes broke or got dislodged. Of course, there was going to be PDPH while placing the catheter. The catheter often would get kinked, and sometimes the practitioner would have difficulty in removing the stylet. These do look a bit scary for us in today's practice, but this was not the major problem with which the catheter went out of vogue. The major issue that was encountered was something called the cauda equina syndrome. So barely a year after they first reported those cases where they used the catheter, the first cases of cauda equina syndrome were reported. So initially there were 2 papers that described 6 cases, all involved using hyperbaric spinal local anesthetic in doses which were rather large. In some cases, up to 350 milligrams of lignocaine were used. In each case, inadequate initial spread of the spinal block led to the local anesthetic redosing, such that the preoperative spinal local anesthetic stacked up and exceeded the normal dose range. 8 more cases were subsequently reported, and 2 years down the line, the FDA banned the use of spinal catheters smaller than 24 gauge in the USA. What exactly is the cauda equina syndrome? Catheters used in the early days were extremely small, about 32 gauge in size, and these small catheters offered immense resistance to the injection such that the injectate would barely trickle out of the end. Catheters placed that would travel caudate were likely to get wedged in the sacral roots, and the slow trickle of local anesthetic would firstly cause abnormal pooling of the local anesthetic such that the local would remain in prolonged contact with the nerve root. This was worsened with the use of high concentration lignocaine, which was neurotoxic, and hyperbaric solutions that would not diffuse into the CSF easily. And because this did not appear to initiate spinal anesthesia, further boluses were given which increased the overall dose. Altogether, this would cause neurotoxicity. However, in today's practice, we no longer use hyperbaric solutions and lignocaine. Catheters are also much larger in size, thereby preventing the occurrence of cauda equina syndrome. Considering that this technique seems to have so many potential risk factors, the selection of patients for continuous spinal anesthesia is very important. We tend to select patients who are high risk, who have severe cardiopulmonary compromise and are at risk with conventional anesthetic techniques. We tend to use this in the elderly where the risk of PDPH is minimal. And we tend to use this in patients who are undergoing lower abdominal and lower limb surgery. So the requirement to use high doses of local anesthetic is quite less. It is not ideal to use this for routine purposes in the young. So this is a typical patient who I recently performed this technique on. It was an 86-year-old with dilated cardiomyopathy and low EF with long-standing comorbids and obesity. And she underwent a hip surgery successfully with continuous spinal anesthesia. Coming to the techniques, there are two sets that are available in today's practice: catheter through needle systems and catheter over needle systems. Catheter through needle systems are what we call the microcatheters. The catheters are deployed through a spinal needle, usually of the Sprotte variety. It's a fairly straightforward method to perform the technique with. Because the catheters are small, they are likely to kink and thereby making the injection difficult. Catheters up to 32 gauge are available, but we normally tend to use about 25 gauge catheters. These small catheters are banned in the United States. So this is a typical set that we use. It involves a 22 gauge Sprotte needle, a 1 ml syringe. The catheter is loaded onto a frame along with a guide wire, and you have a filter and the connector similar as you would find with an epidural set. This is a video of how we perform the technique. Strict asepsis is needed, and the patient is in a sitting position, so this allows a little better flow of CSF. We infiltrate local anesthetic into the desired lumbar space. The Sprotte needle is introduced in a conventional manner till the loss of resistance is felt and there is a free flow of CSF. As you can see, the catheter is extremely thin and is marked according to the distances. And along with the frame, the catheter is fixed onto the end of the Sprotte needle and gently pushed into the intrathecal space. This must be done in an extremely smooth manner. Once the desired length of the catheter is inside, the needle is gently removed. We tend to place the entire frame onto a tray beside the patient and remove the guide wire, leaving only the catheter inside the patient. The connector is fixed to the end and the catheter is adjusted so that only about 3 or 4 centimeters lies within the intrathecal space. We gradually aspirate with a 1 ml syringe, and you can see the trickle of CSF coming into the 1 ml syringe. We don't use syringes larger than 1 ml because the negative pressure often is too much and the CSF flow does not occur. The catheter can then be taped down with a tegaderm. Another type of system is the catheter over needle system. These are a little difficult to find. They are larger gauge catheters, and the deployment of the catheter takes place after prior entry into the epidural space. There is faster flow rates due to the shorter length of the catheter, and this prevents pooling of the local anesthetic. Though they are larger and shorter, the catheters are also prone for kinking. They are apparently designed to reduce the incidence of PDPH, but this is largely unproven, and these are approved for the use by the FDA. So this is a set known as the Wiley Spinal set. As you can see, it has multiple components. There is a 25 gauge catheter, the brown structure that you see, which is loaded over a 27 gauge needle. There is an 18 gauge Tuohy needle with a peel away sheath to facilitate entry into the epidural space. And there is a sort of stent system called the wick wire. There's a syringe for loss of resistance to enter the epidural space. This is a closer look at the catheter which is riding on top of the spinal needle, and if you disassemble these components, you can see this is the spinal needle and this is the spinal catheter. As you can see closely, this is a braided sort of material. This is how the Tuohy needle looks. As you can see, there is a transparent peel away sheath on top of the needle. And this is the wick wire that prevents kinking of the catheter. This is how it is done. We access the epidural space. Once the epidural space is accessed, the Tuohy needle is removed and only the transparent sheath is left behind. This allows us to get a resistance-free conduit right to the dura. So the catheter system is now pushed in, bypassing all the spinal ligaments and going straight into the dura, which you can appreciate with a subtle pop. Once we feel that the system is in, the stylet and the needle are removed, and you should see a small trickle of CSF eventually. The CSF trickling out. Once that is achieved, the catheter is gently pushed inside while peeling away the sheath. After the catheter is completely inside, the sheath is completely removed. The wick wire is placed in there so that the catheter doesn't kink, and the conduct of continuous spinal anesthesia occurs as before. Once the catheter is placed, there are a few steps that you must religiously practice. Determining the initial bolus, maintaining the catheter, and deciding what you want to do with it in the postoperative period. So you need to calculate the priming volume, that is the dead space of the catheter, and initiate the process with small boluses. Usually we use about 0.5 ml boluses. So your initial bolus is going to be the priming volume or the dead space, which is about 0.4 ml in the catheters that you saw, along with the first bolus, which here is 0.5 ml. So if you're starting with 0.5 ml, your initial bolus is going to be about 0.9 ml. You assess the onset and the hemodynamic response and top up accordingly. Whenever needed, if you feel the level is coming down or you need to top up due to the duration of the surgery, you top up in increments of about 0.5 ml. We have at times used 0.2 ml also with success. In the postoperative period, if you want to maintain the catheter, you can leave it in there and use it for analgesia. but I tend to remove the catheter immediately after the surgery to prevent any inadvertent injection into the catheter. If you do maintain it in the post-op period, you can use infusions of very dilute local anesthetic of about 1 ml per hour. Some people use opiates to the solution, and some people have described patient-controlled spinal anesthesia. Beware that you need to use specialized pumps. Your typical syringe pump may not accurately deliver 1 ml per hour. So the problems that we commonly encounter are PDPH if you use it in the younger patients. Mainly it can be technically challenging because we tend to use it in the elderly who already have difficult spines. There is a high incidence of transient paresthesia during placement, but this is usually not permanent. If you maintain the catheter in the post-op, beware of the wrong drug being injected by someone who does not know what the catheter is. The risk of infection is always present with catheter, but we don't have any reports of it with the continuous spinal catheter. Catheters may break, so handle them. Some tips from my side would be consider adding nerve blocks prior to aid positioning of the spinal catheter, especially in lower limb surgeries where fractures are involved. You can give, say, a femoral nerve block to help position, and this will make the conduct of you accessing a difficult spine a little easier. Always use a 1 ml syringe for negative aspiration. You need to have a lot of skill and tact to place it sometimes, and a lot of patience. Don't forget to calculate the catheter dead space before you inject, and remember to always use isobaric or hypobaric solutions to inject. Do not use hyperbaric solutions in these catheters. Thank you for your attention.
Thank you very much, Dr. Amjad, for your very elaborate talk and lucid videos. I'm sure the delegates would have benefited by your presentation, and also the presentations by Dr. Shiva and Dr. Divesh. I'm sure the awake regional anesthesia is actually the true spirit of regional anesthesia is in providing us with to add to our armamentarium the regional anesthesia, the awake technique, which will provide us with an alternative to general anesthesia in the patient who need it most, the most frail patients, where it will be benefiting us. And I'm sure with the talks from all the speakers, the delegates would have benefited and had some valuable insights. I forgot to mention that Dr. Amjad Maniar is currently working as a consultant in Bangalore, India, and he is currently the president of AORA India, and he has done a fellowship from Singapore in regional anesthesia, and he has organized several workshops, and he has taken various faculty lectures in various world congresses and national and international talks, and been a faculty at various national and international workshops. And he has over 17 years of experience in ultrasound guided regional anesthesia. So thank you very much, all the speakers, for your wonderful, excellent talks and excellent videos. I'm sure they all would have, the delegates would be benefited by the talks from all of you. Any questions now are welcome. All of you can put up your questions in the chat box. Right now, I don't see any question. Dr. Jyoti Deshpande has just commented that we can keep the epidural catheter for 48 hours, which reduces the chances of post-dural puncture headache. And there is a literature saying inflammatory action helps to seal. So your comment is very well taken, Dr. Jyoti. I think it is a very well-known fact that now that epidural catheter, if it is accidentally placed intrathecally, it should be left in place at least for 24 hours. Though the literature is equivocal in actually that it actually reduces the incidence of PDPH or not. But yes, definitely it is one of the modalities to try and reduce the PDPH. And now Dr. Sasidharan has asked about which company produces spinal catheter. Any of the speakers would like to answer to this question? Which company produces spinal catheter? I think intralong catheter, which has been described by the speakers.
Yeah, Pejunk intralong catheters
Yeah,
we use.
Pejunk. Yes.
That is what we have been using.
Yeah. So there are no questions for the second session, but Dr. Divesh, would you like to tell the delegates about your personal favorite technique for proximal humerus fracture patient who is a frail patient and where we cannot afford to have a phrenic nerve palsy?
So my personal favorite is a superior trunk block, and I combine the supraclavicular nerve from the cervical plexus and use just 6 to 10 ml. I do not go with a preconceived notion that I have to use this much of drug. It's the bathing which is important.
Absolutely.
And first and foremost is we try to optimize. If the patient is facing any exacerbation like dyspnea, bronchi, so we convince our surgeons just to wait for a day or so because these are semi-emergencies until and unless it's a neurovascular compromise. So this is how we do it. And I showed you the conduct. It was actually a COPD patient. So we give supplemental oxygen, ETCO2 monitoring.
Yeah.
And so we do not put the drapes on the face because it can lead to claustrophobia and a L-shaped screen.
Yeah.
And the slide open and little bit music if the surgeon is comfortable. So this is my recipe.
Yeah. Excellent talk, and your points are well taken. You said that you do not have any experience regarding the saline wash technique, but I'm curious to know, does it also fades away the motor and sensory block in addition to, reducing the phrenic nerve palsy?
So whatever literature I have reviewed, I found around 8 to 10 articles for that. So surprisingly, in all of them, they said that it would reduce the intensity of the phrenic nerve palsy as well as the duration. But none of them actually have mentioned regarding the block fading away. So maybe by that time the local anesthetic would have seeped into the neural elements, and there would have been a little retrograde diffusion upwards, which would have been limited by saline wash. That's what I can think of. Maybe Dr. Shiva can throw a little bit more light on this.
Even I don't have an experience, but I met few people who did it. They said it will reduce the intensity of block as well.
Yeah.
Yes.
Logically, it should be.
Yes.
Yeah. So same question to you, Shiva sir. What is your recipe, and what if you can give a take-home message to the viewers and the listeners regarding a foolproof strategy for a clavicular fracture, awake surgery for a clavicle fracture?
Yeah. I mean, as far as the clavicle fracture is concerned, both the scut as well as the interscalene along with the supraclavicular nerve block works well. In terms of complication profile, even though we found both the selective and non-selective blocks are equal, but there is a catch in it because what we have measured, the outcome is only 1 point at 30 minutes after the block. But what we need to look at is for the diaphragmatic involvement, we need to see how fast it is. That is it happening in immediately following your block, 10 minutes, 15, 20, 30? That is the onset. At what rapidity it happens, that is number one. And what is its intensity? Is it 100%, 50, 20, 30? And the third aspect is how long. So the decompensation is going to happen when the phrenic nerve involvement is faster, more intense, and for a longer time. So even though the selective and non-selective block, the complication profile is equal, unless we look at the diaphragmatic involvement over a period of time, we cannot get answers for these things. But when we use a lower mass of drugs, the logic is the onset of phrenic nerve involvement is going to be slower. It is less intense and shorter duration. So that is what the future studies has to look at to provide an answer to these particular questions. So always it is better to use what is the drug needed, not to put anything more than that. It is as simple as that. So when the site-specific blocks provides all that you want, it is better to go for it. That is what I would say as of now. So SCUT satisfactorily achieves all these goals. Even if there is some of the patients might have a discomfort, it needs little more local supplementation at that particular site, a minimum fentanyl. So there is no point that we have converted them into GE. So the site-specific blocks are going to stand the time. When it comes to the clavipectoral fascia plane block, even though it looks more site-specific and preserves all the other pulmonary function, unfortunately, its indication is extremely limited because most of the time patients complain some sort of a discomfort and things. So that's what my take on the clavicle fractures.
Can I ask a question to Dr. Shiva?
Yeah.
In the study which you quoted, which you have just finished, your success rate for clavipectoral fascia block was only 40%.
Yeah.
So in anesthesia analgesia, I think 2 years back, there has been an RCT which they have actually compared clavipectoral versus interscalene. And if I remember correctly, I cannot recollect.
Their
It's more
success
than
rate is
90%.
good. Yeah. What they
So
did
why
is
there is so much of discrepancy?
Even a lot of case reports, they have shown very good, excellent analgesia, and I was also surprised at this.
True. So in the study, what you're talking about, Divesh, they carefully selected, they've included only middle third clavicle fractures.
Oh.
Even though the clavicle fracture is middle third, you cannot expect all the time the same. And if there is an extensive comminuted clavicle fracture, this is not working. If the fracture is most towards the lateral end, it's not working. Acromioclavicular joint, it's not working. If the surgeon goes little more medial, there is a problem. So you cannot dictate all these things in every single case. So that's what, to begin with itself, I said, if you wanted to make an impact, we need to have a block which is faster onset, consistent across the variety of situations. You cannot describe for one for this, one for that. It's not going to stay. So in that study, RCT, they have clearly mentioned they have selected only a mid-third clavicle fractures. And in my experience, even though the fracture is common in the middle third, but it not comes very clean, without comminution, thin, lean patient. So if there is a comminution, the spread is not good. As you think, we assume, moment we inject below the clavipectoral fascia, it encircles the entire clavicle. It never ever happens. The cadaver studies have clearly proven that it only soaks the anterior surface, it doesn't go below. And it works only with a very gentle surgeon. It never works with most of the people, as you think. So many patients are very uncomfortable. So in my experience, it's not going to stand the time. As the people more and more do, we will have a clear picture. So that's what my take.
Thanks.
So, thank you, Dr. Shiva, for the excellent insights.
Thank you very much.
And Dr. Divesh also for very useful insights and beautiful talks from all of you. And unfortunately, Dr. Amjad and Dr. Sandeep could not join us for the question and answer session. So now, as all good things come to an end, we will be now concluding this webinar. Before we conclude, I would like to thank our esteemed delegates, speakers, and guests. So as we come to the conclusion of this second World Day of Regional Anesthesia and Pain Medicine, which is organized under the banner of AORA, PRAC, and ISRA, I am overwhelmed with gratitude and joy. It was an absolute privilege to host such an enriching and collaborative event which focused on the fascinating world of awake regional anesthesia. So I'm sure awake regional anesthesia, I truly believe that this the true spirit of regional anesthesia lies in awake regional anesthesia, which enhances and expands our armamentarium for providing anesthesia to very frail and morbid patients. And I would like to extend my heartfelt gratitude to our distinguished speakers for this evening, who shared their vast expertise, groundbreaking insights, and real-world experiences with us. And your contributions have truly elevated the quality of this conference, and they have truly left us inspired. A special thanks to our attendees from across the globe who have actively participated and made this gathering a hub of knowledge for exchange.
I think
I think there is
Anju, we lost.
uh,
Okay, anyway, that's fine. I think we have come to
sorry.
the end. I thanks everyone for participating in this. Hope you all enjoyed the academic feast. Thank you, one and all. Thank you, Dr. Ofelia. It's a very great experience and insightful talk from your side. Thank you, one and all. Let all sign off from this today's webinar. Thank you very much.
Bye.
It was a pleasure to be with you.
Thank you.
Disons